Okay. Good evening, all. In today's session, we are going to discuss the topic intercostal spaces. Okay. Intercostal spaces. Okay. I hope you will be knowing the meaning, definition of intercostal spaces. Okay. In between the ribs. Okay. So intercostal spaces are the spaces between the adjacent ribs and the costal cartilages. Okay. And you know, we have totally 12 ribs, isn't it? From above downwards, we have totally 12 ribs, isn't it? So between the 12 ribs, obviously, we will be having 11 intercostal spaces. Okay. So in each intercostal space, we have 3 intercostal muscles. Okay. We have 3 types of intercostal muscles. What are they? As you see here, if you imagine this one as third rib and this one just below the third rib, this one as fourth rib, this will be the obviously the third intercostal space, isn't it? So in each intercostal space, we have 3 intercostal muscles. What are they? From outside inwards. From outside inwards, we have the 3 intercostal muscles, namely external intercostal muscle, number 1, external intercostal muscle. Just deep to it, we have the internal intercostal muscle. And the deepest one is the innermost intercostal muscle. Okay. So from superficial to deep, we have the 3 intercostal muscles named as external, internal, and innermost intercostal muscles. Okay. And you can see the neurovascular bundle. Okay. Neurovascular bundle. That means the blood vessels and nerves which supply the intercostal spaces. Okay. The neurovascular bundle is located between which 2 muscles? Exactly. Between the internal and innermost intercostal muscles, right? And you can clearly appreciate from this diagram the arrangement of the neurovascular bundle from above downwards is okay. From above downwards, this is the intercostal vein. Below that, we have the intercostal artery. Even below the intercostal artery, we have the intercostal nerve. Okay. So van, you can remember as van arrangement from above downwards. Okay. And you can see some blood vessels, some minute blood vessels, which are related to the lower part of the intercostal space. Those are collateral branches, collateral vessels. Okay, they are not main neurovascular bundle. They are just small branches called as collateral branches. Okay, fine. So from this diagram, I want you to know the 3 layers of the intercostal muscles. Okay, then what is the arrangement of the neurovascular bundle from above downwards? What is the order? Vein, artery, nerve. Okay, fine. So this is the magnified view of the previous diagram. So imagine again, this one has third rib and this one has fourth rib. Okay, so instead of saying third rib, we can say it as upper rib, isn't it? And we can say this one has lower rib, isn't it? Upper rib and lower rib, isn't it? So between the 2 ribs, this is one particular intercostal space, that is third intercostal space, you know, right? And you are able to see the 3 layers of the intercostal muscles, isn't it? Fine. And from above downwards, as we studied, the arrangement is vein, artery, nerve, isn't it? And one important thing is, I told you the typical arrangement from above downwards is vein, okay, vein, artery, nerve, isn't it? But this typical neurovascular arrangement, okay, it is absent. Okay, it is absent in one particular intercostal space. Any idea? Exactly. In the first intercostal space, this typical neurovascular arrangement is absent. Okay, it is vice versa actually. Okay, from above downwards, it will be nerve, artery, vein. Okay, fine. Now, from this diagram, you can clearly appreciate one more important thing. The main neurovascular bundle. Okay, this is the main neurovascular bundle, isn't it? It is, okay, the main neurovascular bundle is located. It is located close to the lower border, close to the lower border of what? Upper rib. Okay. The main neurovascular bundle is located, okay, the main neurovascular bundle is located close to the, fine, lower border, okay, main neurovascular bundle is close to the lower border of the upper rib. What is the importance? During thoracosynthesis procedure, the needle should be introduced close to the upper border of the lower rib. Okay, why? Because close to the lower border of the upper rib, the main neurovascular bundle is present. So in order to avoid injury to the main neurovascular bundle during thoracosynthesis, needle is introduced along the close to the lower rib, close to the upper border of the lower rib. Okay, fine. And these things already we have studied, the three layers of the intercostal muscles: external, internal, and innermost. And try to remember the another name for the innermost intercostal muscle, that is transversus thoracis. Okay, innermost intercostal muscle is also called as transversus thoracis. Okay, and actually the innermost intercostal muscle itself consists of three parts. Okay, we have to remember. Okay, so what are the three parts of the innermost intercostal muscle? Sternocostalis, subcostalis, and intercostalis intimus. Intercostalis intimus. Okay, out of these three parts, the main part of the innermost intercostal muscle is intercostalis intimus. Okay, I will show you in the upcoming slide. We have one image, one picture related to the intercostal muscles. Okay, and these things already we have studied, right? In each intercostal space, the neurovascular bundle lies between internal and the innermost intercostal muscles, and the main neurovascular bundle is closely related to the lower border of the upper rib. From this diagram, you can clearly understand what I am talking in this line. Okay, the neurovascular bundle, main neurovascular bundle, is closely related to the lower border of the upper rib. Okay, fine. And take care of this image. Okay, you can expect this one in image based question. Okay, actually, are you able to see the needle here? Needle is passing through one particular intercostal space. Okay, so what is the procedure you are seeing here? Yes, it is called as thoracosynthesis. Okay, otherwise called as pleural tap. Okay, thoracosynthesis or pleural tap procedure. Okay, what is the purpose of this procedure? Yes, it is done to remove the excessive fluid from the pleural cavity. That condition is called as pleural effusion, isn't it? During pleural effusion, in order to remove the excessive fluid, pleural fluid, okay, this procedure is done. Okay, fine. So needle is introduced in one particular intercostal space. Okay, so here you are able to see the 6th rib and the 7th rib. So obviously this will be 6th intercostal space, right? Are you able to see the three layers of the intercostal muscles here? This is the external intercostal muscle. This is the internal intercostal muscle. This is the innermost intercostal muscle, also called as transversus thoracis. Okay, fine. So we have to remember what are the structures pierced during thoracosynthesis or pleural tap. Okay, from this diagram, can you try to answer the question? What are the various structures pierced during the procedure called as thoracosynthesis? Obviously, the first structure to be pierced is skin, isn't it? Skin, followed by fascia. Okay, followed by fascia. Then we have the serratus anterior muscle. Okay, this is the serratus anterior muscle, this one. Okay, serratus anterior muscle arises from the upper 8 ribs. Okay, so fine. So this is serratus anterior muscle. Followed by serratus anterior muscle, we have three intercostal muscles. Okay, external intercostal muscle. Okay, internal intercostal muscle, and innermost. Okay, innermost intercostal muscles. All the three layers of the muscles. Okay, and here one important thing we should keep in mind. Can you tell me which part of the innermost intercostal muscle is pierced? Is it sternocostalis or subcostalis or intercostalis intimus? That's my question. Yes, it is intercostalis intimus. I told you intercostalis intimus is the main part of the innermost intercostal muscle, that will be the structure which is pierced. It is not sternocostalis or subcostalis. Okay, it is intercostalis intimus, the main part of this muscle. Okay, and followed by the 3 layers of the muscles. Endothoracic fascia will be pierced. Endothoracic fascia will be pierced. Then we have the parietal pleura. Okay, the last layer to be pierced during thoracocentesis is parietal pleura. Specifically, it is costal pleura. The part of the parietal pleura that will be pierced is costal pleura. Okay, parietal pleura, or specifically we can say it is costal pleura. Right? Costal pleura. Costal pleura. So see in this diagram, this is again serratus anterior muscle only. Okay, and I have labeled the 3 layers of the muscles, isn't it? Number 4 is representing in this diagram 1, 2, 3, the 3 layers of the muscles. Okay, then we have the endothoracic fascia. This red color is indicating the endothoracic fascia. Then, as I told, the last layer to be pierced here is what? Followed by endothoracic fascia, we have this one. Okay, this is the costal pleura or parietal pleura. That is the last layer. Okay, that is the last structure to be pierced during thoracocentesis. Okay, and this is the inner layer of the pleura called as visceral pleura. So visceral pleura will not be pierced. Okay, it will not be pierced because visceral pleura is closely adherent to the lungs. Okay, so if you pierce the visceral pleura, then the lung will get collapsed. Okay, so visceral pleura will not be pierced. The final target is reaching the pleural cavity. This is the pleural cavity between the 2 layers of the pleura, from where we are going to remove the excessive pleural fluid. Fine. Okay, so take care of all the things we have discussed here. Okay, and this is the main neurovascular bundle. This is the main neurovascular bundle. Okay, and what are these things you will be knowing? These are the collateral blood vessels. Okay, minute blood vessels. Okay, so as I told already, the needle is introduced. Okay, during thoracocentesis procedure, needle is introduced along the upper border, close to the upper border of lower rib. Okay, so this is the upper rib, this is the lower rib. Okay, so the needle is passing, okay, just close to the upper border of lower rib. Okay, fine. So now for the next 5 minutes, let me talk about the intercostal arteries. Okay, intercostal arteries. Okay, so we have to keep in mind, totally I have told you there are 11 intercostal spaces, isn't it? But I think you will be knowing, out of the 12 ribs, only the first 10 ribs, they are extending to the entire length. Okay, from posterior to anterior. What about the 11th and 12th ribs? Do you see the 11th rib and the 12th rib in this diagram? One side. Okay, they are not extending anteriorly. They are present only in the posterior aspect of the posterior part of the intercostal space. Okay, so the thing is, anteriorly we have only 9 intercostal spaces. Okay, because only 10 ribs are extending anteriorly, isn't it? So anteriorly we have only 9 intercostal spaces, since only 10 ribs are there anteriorly. But posteriorly we have all the 12 ribs. So posteriorly we have 11 intercostal spaces. Fine. This thing we have to keep in mind. Okay, fine. So see here. So totally I told you just now, totally anteriorly there are only 9 intercostal spaces. Okay, so out of these 9 intercostal spaces anteriorly, for the upper 6 spaces, okay, the anterior intercostal arteries, okay, the anterior intercostal arteries for the upper 6 spaces, they are branches of internal thoracic artery. Okay, what about the lower 3 spaces? Out of the 9 lower 3 spaces, Yes, they are branches of musculophrenic arteries. Musculophrenic arteries. Okay. What about posterior intercostal spaces? You know, posteriorly we have all the 11 intercostal spaces. Totally, we have 11 intercostal spaces, isn't it? So you can divide them into 2 plus 9. Upper two spaces, the posterior intercostal arteries. Okay, they are branches of superior intercostal artery. Okay, which in turn is a branch of costocervical trunk from the second part of subclavian artery. Fine. For the lower 9 spaces, the posterior intercostal arteries, they are branches of descending thoracic aorta. Descending thoracic aorta. Okay. So let's try to understand from the diagram. Okay. Here you are able to see this is the internal thoracic artery. This red color is representing the course of the internal thoracic artery, which is a branch of the first part of subclavian artery. Okay. So that's what I have written here. Internal thoracic artery is otherwise called as internal mammary artery, ITA, otherwise called as IMA. Okay, fine. Because it is the main artery supplying the mammary gland, especially in females. Okay, so all the details about the internal thoracic artery is important for entrance exam also. Okay, so you know it is arising from the first part of subclavian artery. Okay. And as you see in this diagram, it is moving almost vertically downwards, okay, just lateral to the sternum bone. This is a very important point actually. Just 1 centimeter lateral to the sternum, we have the downward vertical course of the internal thoracic artery. And when it reaches the 6th intercostal space, okay, at the 6th intercostal space, the internal thoracic artery terminates by dividing into 2 branches. What are the 2 terminal branches of internal thoracic artery? Yes, one is musculophrenic artery, another one is superior epigastric artery. Superior epigastric artery. Okay. And as we studied earlier, okay, the musculophrenic artery will give anterior intercostal arteries for the lower 3 spaces. Fine. And remember the thing about the point about the superior epigastric artery. Okay, the superior epigastric artery, this one, passes through one opening present in the diaphragm called as foramen of Margagni, otherwise called as space of Larry. Okay, and it enters the rectus sheath present in the anterior abdominal wall, and finally it ends by anastomosing with another artery which is coming from below called as inferior epigastric artery. So superior epigastric artery finally ends by anastomosing with inferior epigastric artery within the rectus sheath. Fine. So this is the artery. Superior epigastric artery is the one which passes through the foramen of Margagni, otherwise called as space of Larry. Okay, which is present in the diaphragm. Foramen of Margagni is present in the diaphragm. Thoraco-abdominal diaphragm. Okay. Fine. So this is also again repeatedly asked question. Okay, all the following are branches of the internal thoracic artery except. Okay, so let's study the various branches of the internal thoracic artery. Already I told you for the upper 6 spaces, the anterior intercostal arteries are branches from the internal thoracic artery, directly from the internal thoracic artery. Then this is the main branch actually. It also gives branches to supply the, okay, it also gives the branches to supply the pericardium, okay, and phrenic nerves. Okay, so pericardio-phrenic arteries, then perforating branches of the internal thoracic artery. Internal thoracic artery will give some perforating branches in order to supply the mammary gland. Okay, then you know the 2 terminal branches of internal thoracic artery, right? What are they? One is superior epigastric artery, another one is musculophrenic artery. At the level of 6th intercostal space, within the 6th intercostal space, it divides into 2 terminal branches. Okay, so usually in the exception you will have all are branches of the internal thoracic artery except in exception you will have posterior intercostal arteries. Posterior intercostal arteries are not arising from internal thoracic artery. Only the anterior intercostal arteries are branches of the internal thoracic artery. Fine. And I told you it is superior epigastric artery. It is not superficial epigastric artery, it is superior epigastric artery. Okay. Then I hope you will be knowing the applied aspect of the internal thoracic or internal mammary artery, isn't it? What is it? Yes, it is the most commonly used artery for the coronary artery bypass graft. Okay. So during stenosis of any of the coronary arteries, okay, for bypassing the obstruction, stenosis, which artery is most commonly used as graft? Yes, it is internal thoracic artery. Okay. Internal thoracic artery is used as CABG, coronary artery bypass graft. Okay. And we have discussed already the sources of the posterior intercostal arteries, isn't it? Posteriorly, we have all the 11 intercostal spaces, right? So for the upper two posterior intercostal spaces, the posterior intercostal arteries are branches of what? Superior intercostal artery. Superior intercostal artery, which in turn is a branch of costocervical trunk, which in turn is a branch of second part of subclavian artery. Okay. Second part of subclavian artery will give rise to costocervical trunk. Costocervical trunk will give rise to superior intercostal arteries, which will give rise to the upper two posterior intercostal arteries. What about the third to 11th? That means lower 9 posterior intercostal arteries. They are direct branches. They are directly arising from the descending thoracic aorta. They are direct branches of the descending thoracic aorta. Fine. Yes. Fine. This is the thing we have studied. Okay. Okay. And one more important thing, there are two anterior intercostal arteries. In each intercostal space, we have two anterior intercostal arteries and only one posterior intercostal artery. Okay. So anterior intercostal arteries are paired and the posterior intercostal arteries unpaired. Okay. And what will happen to the two anterior intercostal arteries? One anterior intercostal artery will anastomose with the main branch, okay, with the main branch of the posterior intercostal artery. Okay, fine. The another anterior intercostal artery will anastomose. Okay, another anterior intercostal artery will anastomose with the collateral branch. Okay, collateral branch of the posterior intercostal artery. Fine. Okay. So that's what we have studied here. Okay. Each intercostal space has two anterior intercostal and only one posterior intercostal arteries. Okay. And you know the fate of the uh, intercostal arteries. Okay. How they are terminating, you will be knowing, isn't it? Okay, fine. That's the end of the today's session. Thank you all.
Okay, so today we have finished all the Hodgkin's and non-Hodgkin's lymphoma. Last NEET PG one question was there. The recall question was not properly. I mean, we didn't get the recall question in proper terms. Whether it was benzene or benzidine in the question, we didn't know. But it causes which malignancy was the question. Okay, it causes which malignancy was the question. So we'll just look into ALL today. Fine. So when coming to ALL, okay, when coming to ALL, what are the points you have to know? Okay, ALL is one hot topic for CET that you all know. So what are the topics you have to know? That is, it is the most common cancer of childhood. It's the most common cancer of childhood. That is one thing. Okay, and here when it comes to ALL, in the initial classes of lymphoma itself, I've told you that it is the neoplasm of precursor B or precursor T cell. It can be either precursor B or T cells. That is one point you have to know. Okay, it is childhood. Males are more commonly affected. So these are the general points you have to know. Coming to etiology. Okay, so benzene exposure. See, benzidine is for bladder carcinoma. Benzene exposure is for ALL, acute leukemia. So this was the confusion in the previous NEET PG, if it was benzene or benzidine. But in the option, few of the students recall telling that there was no leukemia. If leukemia was given, benzene is the, for benzene, it is the right answer. For there was bladder, so I assume the question was benzidine. So benzidine causes bladder tumor. Okay, that is one thing among etiology. Amongst etiology, one more important thing is ionizing radiations. Ionizing radiations. Okay, and then we have hereditary factors, which includes Downs. Okay, if the patient is having Down, he's more prone for ALL. Okay, Fanconi's, Bloom's, ataxia telangiectasia. Question: all of the following lead to ALL except, or are the risk factors for ALL except, was the question around 3 or 4 years back. So Downs, Fanconi's, Bloom's, ataxia telangiectasia, and Klinefelter syndrome. These are the things you have to remember. Okay, so as we know, there are two types. Okay, morphologically, they can either be pre-B cell or pre-T cell. Okay, so amongst these both, pre-B cell is the most common. Okay, and it occurs in childhood, usually 2 to 5 years, and this occurs in adolescence. Okay, this occurs in adolescence. Fine. And this, whenever it is T cell, no, it will manifest as tissues. Okay, so it will either manifest as mediastinal mass, most commonly mediastinal mass, or testicular mass, or CNS. It will invade the tissues quickly. Okay, it will extensive involvement of the bone marrow, and we will see cells on the peripheral smear. Okay, extensive involvement of the bone marrow, and we will see cells on the peripheral smear. B, okay, lymphocytes, and then it will be in the bone marrow or peripheral smear. T lymphocytes, it is most commonly, so pre-T cells, it is most commonly seen in tissues. T for tissues, you can remember it like that. Okay, so whenever it is pre-T or pre-B, TDT will be positive. This is an important MCQ question you have to remember. When they give you flow cytometry image, I will show you. If TDT is positive, it is going to tell you that it is either pre-B or pre-T cell. Okay, you know that if it is B cell, what are the markers? Okay, we'll come to the phenotype later. So we'll come off to the, when looking into the molecular genetics, okay, what you have to remember in pre-B is translocation 1221. hyper or hypodiploidy. Both can occur in B lymphocytes. Okay, precursor B ALL. Hyper or hypodiploidy. Translocation 1221. Okay, loss of function mutation of PAX5 gene. Loss of function mutation of PAX5 gene. Fine. When it comes to T cells, you will not see this hyper and hypodiploidy. You will see gain of function mutation of NOT gene. NOTCH is NOT gene is associated usually with T cells. PAX5 is with B cells. That is one dictum. You have to know that. Okay. NOT is usually with T cells. There is a T. You can remember it like that. PAX5 is usually with B cells. PAX5 is usually with B cells. Okay, hyper and hyperdiploidy is associated with pre-B cell. Fine. Then what are the clinical features? What will be the clinical features? Clinical features, of course, will be, there will be lymphocytosis. Okay, along with that, the patient will have anemia, neutropenia, so they're more prone to infection. Okay, thrombocytopenia. Okay, generalized lymphadenopathy, okay, splenomegaly, okay, and hepatomegaly can be seen. Fine. And whenever it is T cells, testicular involvement, CNS involvement will be seen, most common with T cell. Fine. These are the clinical features. These are the clinical features. So now let's look at the morphology for image-based questions. So FAB used to classify it as L1, L2 and L3 blast. Now it is outdated. Okay. So L1, L2 and L3 blast. L1 are smaller cells. Okay. They have scant cytoplasm. Okay. Of course, they will have a dense chromatin. Okay. And they will have prominent nucleoli. Fine. L2 blasts are larger. So one more point here, it is scant cytoplasm. No granules in the cytoplasm. Okay. Here we may see granules. Okay. They are little larger. You will see more amount of cytoplasm. L3 characteristic, it will look like Burkitt's lymphoma cells. Okay. So they have royal blue cytoplasm with cytoplasmic vacuoles, okay, and large nucleus with nucleoli can be seen. This stain is TDT stain, which is going to be positive in all the pre-B and pre-T cell ALL. Fine, this is for TDT. Important image-based question. So if you see smaller cells, it is L1, a little larger cell, it is L2. And Burkitt's type with vacuoles, it is going to be Burkitt's type or L3. It's going to be Burkitt's type or L3. So coming to the prognostic factors, very, very important. We have to know what are the good prognostic factors, what are the poor prognostic factors. Okay. Usually when the age group is between 2 to 10 years, they say it is good prognostic factors. Okay. So here, the child between 1 to 10 years. Okay, when it is more than 10 years or less than 1 year, it is going to be poor prognosis. Males, poor prognosis. Females, good prognosis. B cell, you already know it is good prognosis. T cell is poor prognosis. Why? Because it is CNS involvement, testicular involvement is very high. Tissue infiltration is very high. Okay. Fine. And when coming to count, if the count is low, less than 50,000, it is going to be good prognosis. If it is more than 50,000, it is going to be bad prognosis in case of B cell ALL. In case of T cell ALL, if the count is more than 1 lakh. If the count is more than 1 lakh. Okay, fine. Among other than this, what is important for you all is, see, hyperdiploidy has good prognosis. Hypodiploidy has poor prognosis. Okay, hyperdiploidy, hypodiploidy. Okay, fine. Then MLL gene is poor prognosis. I want you to remember that. And 922 BCR ABL translocation, if it is there, it is poor prognosis. See, BCR ABL you will find in, see, it is recently included in, it's a provisional entity included in ALL, isn't it? So when you see this translocation, in case of CML, the tyrosine kinase which is produced is 210 kilodalton question. In case of ALL, okay, in case of ALL, it is 190 kilodalton. This is having a more potent tyrosine kinase activity. More potent tyrosine kinase activity. Okay, fine. This is one thing which we have to know. And then, see, this is the image from Robin. So I just put it up for you. Okay. So if you see, these are L1 type of blasts. Okay. Scant cytoplasm. So if this image is there, that is from Hoffman, this is from Robbins. If you find this image also, you have to be able to pick it up. So flow cytometry is going to be important. See here, when it is B cell type, CD10 is common ALL antigen, CALA. So that will be positive. See, in this flow cytometry, we are seeing the group, this group of cell. When it is this quadrant, both are positive. When it is this quadrant, only this is positive and this is going to be negative. When it is this, both are negative. When it is this is positive and this x-axis is going to be negative. So this group of cell is CD19 positive and CD10 positive. Okay. And again, this group of cell is TDT positive and CD22 positive. It is going to be pre-B cell ALL. Important image-based question. It is going to be pre-B cell ALL. Fine. So these are the important points about ALL. What I want you to remember here is the images. So L1, the blasts are smaller. L1, the blasts are smaller. L2, a little larger. The cytoplasm, you will find moderate amount of cytoplasm. Granules will be there. L3, what is important is vacuoles in the granules. TDT, if it is positive, it is going to tell you it is either pre-B cell or pre-T cell. Okay, and then most important is benzene is going to cause it. And what are the hereditary, defects which are going to lead to is Downs, Bloom's, ataxia telangiectasia, okay, Klinefelter syndrome, Fanconi's. Downs, Bloom's, ataxia telangiectasia, Klinefelter's and Fanconi's. Fine. Okay, and then you have to know the good and poor prognostic factors. And this question is very, very important. What is the weight of tyrosine kinase in ALL because of due to BCR ABL translocation? It is 190 kilodalton, and it is more potent tyrosine kinase activity. The tyrosine, it is a stronger tyrosine kinase activity. That is why whenever there is a BCR ABL translocation in case of ALL, it is poor prognosis. It was told to be poor prognosis, but when we have drugs targeting that, the survival is good. And one more poor prognostic factor amongst genetics which is there in ALL is MLL gene mutation. In case of B cell, it's going to be PAX mutation. In case of T cell, it's going to be Notch gene mutation. Okay, Notch gene mutation in case of T cell, PAX mutation in case of B cell. Okay, loss of function in case of PAX. In case of Notch, it is going to be gain of function mutation. Right. So this brings us to the end of the class. Thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Good evening, students. We'll start discussing some important topics in microbiology. We'll start with filariasis, very important MCQs topic. So we'll start with how we classify human filarial worm. So we classify them into, first is your lymphatic filariasis. Okay, as the name indicates, they causes lymphatic infection. Then second one is your subcutaneous filariasis. Then third one is serous cavity filariasis. So you are dividing lymphatic, subcutaneous and serous cavity filariasis. So which all are the filarial worm which causes lymphatic filariasis? So we have Wuchereria bancrofti, Brugia malai and Brugia tumori. These three are which causes lymphatic filariasis. Which causes subcutaneous filariasis? So we have Loa loa, Onchocerca volvulus and Mansula streptocara. So these three are which causes subcutaneous filariasis. Loa loa is also called Calabar swelling, so which has been asked previously in some state entrances, like what is Calabar swelling? So that is nothing, the infection, subcutaneous infection caused by Loa loa. Okay. Onchocerca volvulus, which causes river blindness, and Manzanella streptocara causes skin infections, skin diseases. We have serous cavity filariasis, which caused by Manzanella ozadi and Postins. Now coming to see their morphology, how they are arranged, how their nucleus, how their tail end, anterior end and all are arranged, because you get plenty of question on this morphology. So you should remember whether they are sheathed or unsheathed filarial worm. So in unsheathed, you have only two, which are unsheathed: Manzanella postins and Manzanella ozadi and Onchocerca volvulus. So you have three unsheathed one. Okay, Manzanella and Onchocerca volvulus. Now, which all are sheathed? So you have Wuchereria bancrofti, Brugia malai, and Loa loa. These all are sheathed filarial worm. Okay. Okay. Now, where is habitat? So all of them habitat is blood except Onchocerca volvulus, where habitat is skin or eye. So these are the habitat of Onchocerca volvulus. Now coming to how their tail end is arranged, how the nucleus at the posterior end or tail end arranged. You can see the picture. Tail nucleus do not extend to the tail tip. Okay, that is your Wuchereria bancrofti, which has been asked in this year NEET entrance. Two nucleus at the tail tip, which is your Brugia malai. Okay, the picture I will show you here. The picture is better here. So the first picture is your Wuchereria bancrofti tail end. So you can see there is no nucleus. These are sheathed. You can see the sheath. Okay, this is the sheath. Okay, this is the sheath. So this is the worm inside. You can see the tail at the tail tip. There is no nucleus. So tail tip is free of nucleus. Okay, so in this NEET entrance, you had got this question, right? Then you have Brugia malai. Okay, so you can see that is also sheathed. You can see the sheath here. There is two nucleus. You can see two nucleus which is present at the tail tip. Okay, now Loa loa, which have nucleus extending to the tail tip. Nucleus extending to the tail tip. Fourth one, Onchocerca volvulus, no nucleus at the tail tip, but you can differentiate from Wuchereria bancrofti, which are, because this is sheathed and this is unsheathed. Okay. Now, Manzanella also doesn't have sheath and no nucleus at the tail tip. Manzanella streptocara also no sheath, but nucleus extend up to the tail tip. Now coming to periodicity. which is nocturnal, which is diurnal, because you get a question, Wuchereria bancrofti, whether it's nocturnal, diurnal. So please remember Wuchereria bancrofti, Rugia malai and Rugia tumori, these three are nocturnal, means larval comes in the peripheral blood during nighttime. Okay, which is diurnal. Loa is diurnal, can be daytime, nighttime. Subperiodic, you see in some strain of Wuchereria bancrofti and Rugia malai. Okay, aperiodic is your Mansonella. Okay, so nocturnal or subperiodic is your Wuchereria bancrofti. Diurnal is your Loa. The clinical feature. Okay, so how the patient present with lymphangitis, lymphadenitis, epidermolysis orchitis, mastitis in a female, lymphedema, elephantiasis. Elephantiasis, lymphatic obstruction leads to swelling of the limb, lower limb, and it's present like a elephant leg. So we say it as a elephantiasis, very heavy leg, swollen leg, and it can lead to hydrocele or chyluria. Okay, what is classical and occult filariasis? Okay, classical is because of developing worm or adult, you get a filarial infections. When you get in cause of those manifestation is microfilaria, you say it as a occult filariasis. And this is actually a hypersensitivity reaction. Okay, this is acute inflammation. This is hypersensitivity reaction. You get a eosinophilic granuloma formation. It can affect lymphatic system. Apart from that, it can affect lung, liver, and spleen also. It will be present in affected tissue, but not in the blood. This will be present in the blood. And classical filariasis does not respond well to drug. Occult filariasis, which happens because of microfilaria, respond well to the antimicrofilarial drug and diethyl carbamazepine. Now coming to second topic, hookworm, right? Hookworm, which we say Ankylostoma duodenal. Okay, so which is hookworm? Old world hookworm is your Ankylostoma duodenal, which is new world hookworm, Nectar americanus. Okay, which causes creeping eruptions is your Ankylostoma brasiliensis and caninum. Okay, these are mainly the animal hookworm, which accidentally causes human infection. So these leads to creeping eruptions. What is the habitat of this hookworm infestation? As I discussed you earlier and said you should be remembering habitat of each worm. Okay, so habitat is duodenum and duodenum also less often. Okay, and this is the egg of the hookworm. You should be remembering the egg, which is elliptical, which is plano-convex, these all, which is barrel shaped, these all you should remember. So this is the egg of hookworm, which is not bile stain, non-bile stain egg you see in a hookworm. So there is a clear space between these are the segment, okay, and there is a clear space between segment. So which all are non-bile stain egg? Okay, you remember mnemonics henna. Henna, in that H stands for your Hymenolipis nana, E stands for Enterobius vermicularis, N stands for Nectar americanus, A stands for Ankylostoma duodenal. So these all are your non-bile stain egg. Okay, so you get to non-bile stain, you have to remember the mnemonics henna. Okay, which all are bile stain egg. So bile stain egg, you have bat. Please remember the mnemonics bat. B for bile stain, A for Ascaris lumbricoides, T for your all T, Tinea solium, saginata, trichura. So these all are your bile stain. While they are yellow in color, so they are called bile stain. They will be non-bile stain will be colorless. Okay, how the human get infection in hookworm? So mainly it's seen in the people who walks barefoot, okay, And this filariform larvae is the infective form, okay, which penetrates the skin. Where the penetration happens? Between toes or dorsum of feet or inner side of sole. Okay, so infection can happen through contaminated food and water, and most other common cause is through filariform, which causes skin penetration. Okay, so one of the very characteristic feature of is hookworm anemia. There are few parasites which causes anemia. One of them is hookworm. We discussed yesterday pernicious anemia, right? This causes microcytic hypochromic anemia. Okay. Pernicious anemia we discussed for diphyllobothrium. Hookworm causes microcytic. Malaria causes normocytic pneumochromic anemia. So this has been asked previously, around how much ml of blood one hookworm ingest. So if it is Nectar americanus, it is around 0.03 ml per day they suck the blood. So blood loss is this much. Ascaris lumbricoides, 0.1 ml per day. So that much blood loss is there. So blood loss is one of the cause. They suck the blood, so that much loss is there. That is the cause of anemia. Plus they secrete some anticoagulant substance also. So that also leads to blood loss. Now coming to ascariasis. Ascariasis, most common mode of transmission is contaminated food or water. Apart from that, inhalation of contaminated dust can be other cause, or children playing in contaminated soil can acquire parasite through their hand. Okay. Ascaris, we have two types of egg, fertilized and unfertilized egg. What is Loeffler serum? This has been asked plenty of time. Loeffler serum. So what is that? Pulmonary eosinophilia. The life cycle, during their life cycle, Ascaris worm crosses through the lung. But there, it causes milder respiratory symptom leading to eosinophilia, and other manifestation like low fever, non-productive cough, dyspnea, hemoptysis, that will be there. Plus, patient will present with eosinophilia, that is called Loeffler syndrome, which we see in ascariasis. We can also see this in hookworm infestation and strongyloides also, because in those worm, the life cycle crosses through lung. If the one option you have to select, then you should go for Ascaris lumbricoides. We'll discuss one more, Strongyloides turcoralis. Strongyloides turcoralis. As we discussed, this can be one of the cause of Loeffler syndrome. So this infection which we see mainly in immunocompromised patients. Okay, so this parasitic infection we see mainly in the immunocompromised patient, immunosuppressed patients like your HIV positive patients or any other immunocompromised patient. Okay, here we see hyperinfection syndrome. Okay, and you can detect larval form in the sputum sample. So these all three are very important points about Strongyloides turcoralis, the infection which we see commonly in immunocompromised patient, and it leads to hyperinfection syndrome, and larval form can be detected in the sputum sample, which has been asked in your NEET 2021. Thank you. Thank you, students. So we'll meet tomorrow again with some important topic in microbiology. Thank you.
So shall we start? So I think we're online. Shall we start? Yeah. Okay. So we shall see another INICET preference topic today. So the topic is brain contusions and hemorrhages, right? With respect to forensic medicine. Fine. So what are all the traumatic brain contusions that are possible with respect to brain is one, coup contusion, right? Coup contusion. Second one is contra-coup contusion. So I'll tell you what those are all in detail. So third is intermediary coup, and fourth is gliding contusion, and the fifth one is herniation contusion, right? Herniation contusion. So coup contusion is nothing but contusion of brain substance or brain matter occurring at the site of impact, right? You could see at the site of impact. So there is a force acting on head. So contusion develops on brain at the site of impact, right? Or at the site of or underneath the surface of injury, right? Underneath the surface of actual injury or actual impact, we can say. Close to impact, right? So this is coup contusion, right? Close to the site of impact, right? Site of impact. So please remember site. Site is the most important word here, right? Then what is contra-coup? See, contra-coup is a DNB favorite. See, contra-coup is nothing but contusion in brain developing at a site diagonally opposite, right? Diagonally opposite site. So it is diagonally opposite site. So diagonally opposite to what? So diagonally opposite to the impact, right? Diagonally opposite to the impact. You could see now here is the impact. Now this is coup lesion. So this is contra-coup lesion. So diagonally opposite, right? Contra-coup lesion. So at the site of impact, coup. Diagonally opposite to the site of impact, contra-coup, right? Now what is intermediary coup? Intermediary coup. So please pay attention. Now if you draw an imaginary line that is connecting coup lesion with contra-coup lesion, right? Coup lesion with a contra-coup lesion. Now this yellow color line connects the coup lesion with the contra-coup lesion, right? So if you connect coup lesion and the contra-coup lesion with an imaginary line, and if there is a bleeding in the imaginary line, it is called intermediary coup, right? Intermediary coup. So intermediary coup is nothing but contusion in the brain substance that is along the line connecting coup lesion and contra-coup lesion, right? Now what is the fourth one? Gliding contusion. Gliding contusion. See, gliding contusion, you have 2 points to remember with respect to gliding contusion. One is gliding contusion occurs more commonly due to rotatory vein, right? Rotatory vein rupture. Right? Rotatory vein rupture. Right? Rotatory vein rupture. And where it will be? So it will be on the top of parietal lobes. Top of parietal lobes, right? Parietal lobe. Parietal lobe. So I'll take this out. so that so what is the next one? That is herniation contusion, right? Herniation contusion. See, herniation contusion is nothing but contusions in brain developing due to herniation, right? Herniation of brain into foramen magnum or under tentorium, right? Tentorial herniation or magnum herniation. So herniations developing as a result of increased ICT, right, will give rise to herniation contusion, right? Herniation contusion. Okay, so we'll see photos for each. Right. So look at this. Now this is the actual site of impact. This is hoop lesion. Hoop lesion. Now look at the frontal lobes. The frontal lobes. The frontal lobes are diagonally opposite, right? They are diagonally opposite to the original site of impact, or they are contricoop, right? Contricoop. It is contricoop, not counter. It's contri, right? Contri. Now, like I told you, the imaginary line connecting the coop lesion and the contricoop lesion, the line connecting the coop lesion and the contricoop lesion, you could see the contusion here, right? Contusion here. Now, these are called intermediary coop, right? Intermediary coop. Intermediary coop. Okay. Then now, where will be the gliding contusions that we saw in the previous year? Gliding contusion will be on the top here, exclusively here, right? Here. Gliding contusion on both sides, on the top, right? On the top. Gliding contusion because of gliding of brain, right, under the skull, right? Gliding contusion. Okay. Now, in the last photo, you could see the herniation contusions. You could see the herniation contusion, right? Because of herniation, so brain substance is subjected to maximal stress, and it goes for contusion, right? So now we'll go to hemorrhages, right? Hemorrhages, intracranial hemorrhages. So the first type is extradural hemorrhage, extradural hemorrhage or extradural hematoma. Extradural hemorrhage or extradural hematoma. See, the extradural hematoma is between dura and the skull. Dura and skull. Between dura mater and skull. Okay. Now, the reason or underlying pathology for extradural hematoma is rupture of middle meningeal artery, right? Posterior branch of middle meningeal artery, to be exact. Posterior branch of middle meningeal artery, right? So this is the most common pathophysiology. Okay. Rarely, anterior meningeal artery damage due to cribriform plate fracture, anterior meningeal artery involvement due to cribriform plate fracture, or posterior meningeal artery due to foramen magnum fracture, right? Or anterior ethmoidal, right? Anterior ethmoidal artery involvements can give rise to EDH. Okay. Now, very rarely, sagittal sinus or transverse sigmoid, right? Transverse sigmoid sinus damage can give rise to extradural hemorrhage, right? So mostly middle meningeal artery, posterior branch rupture. So rarely anterior meningeal if there is fracture of a cribriform plate of ethmoid, or posterior meningeal in foramen magnum fracture, or anterior ethmoidal artery involvement, or sagittal sinus or transverse sinus involvement can give rise to EDH, right? Now, another important point we have to remember about EDH is almost always due to trauma. Traumatic. It is always traumatic, right? Almost always due to trauma. There could be fracture, right? There could be a linear fracture associated with it. Okay. Now there is one more entity called lucid interval, right? Lucid interval, which means period of consciousness. Remember, lucid interval means period of consciousness. Period of consciousness between two periods of unconsciousness, right? So EDH classically exhibits lucid interval. So period of consciousness between two episodes of unconsciousness, right? This is extradural hematoma, right? Now we'll go for subdural hematoma, right? Subdural hematoma. Subdural hematoma. Now, subdural hematoma is due to rupture of bridging veins, right? Bridging veins, rupture of bridging veins. So rarely it could be due to cortical vein or inferior cerebral vein involvement or secondary causes. Secondary causes like drugs, right, or aneurysmal rupture or hypercoagulable states can give rise to subdural hematoma. Okay, right. Now, subdural hematoma is more commonly seen on the convexities, right, on the convexities of the brain, convexities of the brain. Okay. So now, subdural hematoma can also exhibit lucid interval, but how do we differentiate lucid interval between due to EDH and subdural hematoma? See, in EDH, the lucid interval is between 2 to 4 hours, right? 2 to 4 hours. Whereas in subdural hematoma, the lucid interval is appreciated between 2 to 4 weeks. So easy to remember, right? So 2 to 4 hours extradural hematoma, 2 to 4 weeks subdural hematoma, right? The time of onset of lucid interval, right? Now, another image-based question, the recent trend is the shape of EDH and shape of SDH. See, EDH extradural hematoma will try to strip away the dura mater. It will try to strip away the dura mater. Whereas SDH, subdural hematoma, will form a convex shape, right? A convex shape. Now, the third one, subarachnoid hemorrhage. Now, the subarachnoid hemorrhage, right? It is the most common traumatic intracranial bleeding. Most common traumatic intracranial bleeding is subarachnoid hemorrhage. Right? Because even slightest trauma on the head will produce subarachnoid hemorrhage. Okay. Now, subarachnoid hemorrhage can be due to trauma. Yes, it can also be due to aneurysmal rupture or brain substance injuries, like a direct laceration, right? Or a burst lobe. There is an entity called burst lobe, which is nothing but laceration combined with subdural and subarachnoid hemorrhage of the brain, right? Laceration combined with subdural hematoma and subarachnoid hemorrhage, right? They're in combination, it is called burst lobe. Okay. Now, another repeat MCQ here we have to remember is, see, if we open skull, there is bleeding between skull and dura mater. It is extradural hematoma, right? Extradural space, extradural hematoma. So if we reflect dura mater, that is under dura. So in between dura and arachnoid, what we have is subdural hematoma, right? Under dura, but above arachnoid, right? Okay, leave it. Now here, how do we differentiate subdural hematoma from subarachnoid hemorrhage? Right? So remember, EDH between skull and dura. Okay. Now what is SDH? Subarachnoid hemorrhage between dura and arachnoid. So this much we already know. Now it is so easy, just a matter of anatomy, so easy. So subarachnoid hemorrhage and subdural hematoma, how do we differentiate in autopsy? So easy. Take the brain, pass a stream of water or a gentle stream of water, to be precise. The gentle stream of water will wash away subdural hematoma. Subarachnoid hemorrhage will remain intact. All right, so easy, because we have only reflected dura mater and we have taken out the brain, because the subarachnoid hemorrhage is under arachnoid, right? It is under arachnoid. It is between pyometer and arachnoid. So we cannot remove arachnoid and pyometer. It it will peel off the brain itself, right? So in dissection, what we do, we reflect only the dura mater. So below dura mater, two hematomas are possible. So one is subdural hematoma, next is subarachnoid hemorrhage. So how do we differentiate? Easy. Take the brain, pass water, water will completely wash away subdural hematoma. Now subarachnoid hemorrhage will remain as such, or subarachnoid hemorrhage will continue to be reddish, and it is continues to be reddish and attached to the brain substance, right? Brain substance. So this is how we differentiate subdural hematoma from subarachnoid hemorrhage, right? Okay. So with this, we'll close today, and tomorrow we'll meet again with another topic, right?
So moderator, am I audible? Just confirm. Moderator, am I audible? Yeah, so let's start. So today's again, we'll continue with yesterday's topic, that is new drugs for 2021. Okay. So first new drug which we are going to see here is phenerenone. So we all know about spironolactone and eplerenone, but this is something called as phenerenone. So what is the difference between these group of drugs? Spironolactone and eplerenone are steroidal mineralocorticoid antagonists. They are steroidal mineralocorticoid antagonists, whereas phenerenone is a non-steroidal mineralocorticoid antagonist. So it does not act in any of the other. So it does not act in any of the other steroidal receptors. So that is one difference. So phenerenone is a new drug which is a non-steroidal mineralocorticoid receptor antagonist. So it is mainly a potassium sparing diuretic. Why? The normal action of mineralocorticoid is what? To preserve the sodium inside, to knock out the potassium outside. So what does this do? If the antagonist is used, the sodium is pushed out, the potassium is spared inside. So hence it's a potassium sparing diuretic. What is the use that has been approved by the FDA? It is approved in kidney failure in type 2 diabetic patients as well as chronic kidney disease to reduce the kidney failure. There is evidence that shows 40% reduction in kidney disease. So mainly this is given in type 2 diabetic mellitus as well as CKD patients to reduce your kidney failure. Also to reduce cardiovascular deaths and sometimes non-fetal heart failure as well. These are the proven conditions where this has been used and is approved for FDA. The known side effects with the steroidal mineralocorticoid antagonists like impotence, gynecomastia, decreased libido are not seen. So this does not have those side effects. The only side effects noted is with respect to the action of the drug. That is your hyponatremia, because it is pushing the sodium out. Hyperkalemia, it is a potassium sparing diuretic. Hypotension, since it is used, is going to push your sodium out, there is a reduction in the body volume. So it might result in hypotension. So this is the first drug which we have seen today, that is phenerenone. It's a non-steroidal mineralocorticoid receptor antagonist. They might give options like pick out the potassium sparing diuretic, which is non-steroidal mineralocorticoid receptor antagonist. So your answer should be phenerenone. See, it has decreased affinity for steroidal receptor. So side effects are very less. The second drug will be fexinidazole, like metronidazole, fexinidazole. So this is a nitroimidazole. as we all know, this is a nitroimidazole. So what does this used for? What is it used for? It is used for sleeping sickness, that is African trypanosomiasis brucei, trypanosomiasis brucei, sleeping sickness. So it is usually given oral. It is available as 600 mg tablet. So these are all nitroimidazole group of drugs. So how does this act? See, the mechanism of action is very complex actually. It's not much detailedly given. I would like to tell you some points which they might ask with respect to this mechanism. This trypanosomiasis has some bacterial like nitroreductases enzymes, okay, that is encoded by this trypanosomiasis. So what happens when the reduction takes place? This activates fexinidazole. When you take fexinidazole in a patient with sleeping sickness, the bacterial like nitroreductase is already present, which is encoded by the trypanosomiasis, activates your drug and converts that into metabolites. Two metabolites are formed. One is sulfone, other one is sulfoxide. These metabolites help in damaging the DNA and proteins of the trypanosomiasis parasite. So it is very different sort of mechanism. The drug is getting activated by the nitroreductases that is encoded by the trypanosomiasis. Then they metabolize to two metabolites, which is sulfone and sulfoxide metabolites, which damages the DNA and proteins. One catch point here is it is used for both first stage and second stage of trypanosomiasis. What is first stage? It is hemolymphatic stage. Your lymphatic system and the blood vessels are affected by the parasites. The second stage is your meningoencephalitis. The brain gets affected. It's an advanced disease. So in both the stages, it is effective. Criteria is greater than 6-year-old patients can be used, greater than 20 kg body weight. As per clinical trials, they have given some criteria. So how do you use this? Initially loading dose you have to give. That is 1 to 4 days. First 4 days will be loading dose. Total is 10 days. First 4 days is loading dose. 1800 mg per day you have to use as loading dose. But you can give it as 3 tablets, 600, 600, 600. The next 5 days, that is 5 to 10 days, including 5th day, it is 6 days. 5 to 10 days, you give 1200 mg per day, 2 tablets of 600 BD dose. This is also 1800, 3 tablets for 4 days, 5 to 10 days, 1200 mg BD dose. Okay. Adverse events noted, very, very common adverse, QT prolongation, disulfiram-like reaction with alcohol or disulfiram. So whenever this drug you are taking, you are not supposed to drink alcohol or take disulfiram tablets because it can cause disulfiram-like reaction. Disulfiram-like reaction means stomachache, headache, irritability, nausea, vomiting. Many features are there. Psychosis even presents as disulfiram even presents as psychosis and mood irritability. Then neutropenia, elevated liver enzymes. It can also cause psychosis as adverse event. One catch point here is it is not yet approved by FDA for this particular condition, visceral leishmaniasis, but it has proven good results, shown good results. They might ask in these aims. Fexinidazole, FDA approved drug for sleeping sickness, can also be used for visceral leishmaniasis. So fexinidazole easy, 600 mg oral sleeping sickness, nitroreductases present encoded by the trypanosomiasis activates into metabolites and converts them into metabolites. Sulfone, sulfoxide damages the DNA. Greater than 6 years old, 20 kg body weight criteria. Both the stages, first and second stage, hemolymphatic meningoencephalitic stage. Loading dose 4 days, 1800 mg per day, 3 tablets, 5 to 10 days. Maintenance dose 1200 mg per day, BD dose 600, 2 tablets. QT prolongation, disulfiram regression. So do not use it with alcohol, disulfiram, neutropenia, elevated liver enzymes, and psychosis. It is tried for visceral leishmaniasis and shown positive results as well. So coming now to the third drug, which is a very new drug that is called as relugolix. It is called as relugolix. So it is nothing but G. Note this G, relugolix. So it's a GnRH receptor antagonist. So if GnRH receptor is going to get blocked by an antagonist, what will happen? There is a decrease in your LH and FSH levels. If LH and FSH is decreased, what is going to reduce? Your testosterone is going to reduce. Okay. So mainly this is used when it is used where testosterone levels are high. So it's an oral drug. So where testosterone levels are high is advanced prostate cancer in adults. It is used. So how it is used? 360 mg loading dose. It is started with and then 120 mg daily for a month you have to give. So it keeps on repeating till the testosterone levels reduces and there is some reduction in the shrinking of cancer size. So adverse events noted is AUB. What is AUB? Abnormal uterine bleeding. Heavy menstrual bleeding is also noted. Headache. Decrease in bone density. There is a decrease in the bone density. So you have to measure bone density periodically every 3 months when you are using this drug. So diarrhea can also occur. Muscle pain and sweating. One metabolic thing which it causes is it increases your glucose levels. Also liver enzymes are affected. So it should not be given in pregnant females. It can cause fetal harm. Even it can lead to abortions as well. QT prolongation. This also causes QT prolongations. So relugolix, GnRH receptor antagonist, oral drug. It is used for reduction of testosterone. So it is used for advanced prostate cancer in adults. So loading dose 360 mg and then continue with maintenance dose of 120 mg daily. So I have noted here something. Avoid with CYP3A4 inducers. Avoid with CYP3A4 inducers. The action might reduce because it is metabolized by CYP3A4. It might decrease the effect of the drug. It is also being tried for endometriosis and fibroids. It is also being tried for endometriosis and fibroids, but FDA approved for prostate cancer. Adverse events, abnormal uterine bleeding, heavy menstrual bleeding, headache, bone density reduction, increased sweating, muscle pain, glucose levels are increased, fetal harm it can cause, so not safe in pregnancy, QT prolongation. So coming to the question of the day, a 40-year-old male, okay, was diagnosed with sleeping sickness, okay, and was started with nitroimidazole group of drugs. So nitroimidazole means what are those? Tinidazole, metronidazole, fexinidazole, newer one. We have oral route at a dose of loading dose, 3 tablets. On third day, the patient attended a party and consumed alcohol. 3 pegs he has consumed. After 45 minutes, the patient experienced nausea, vomiting, flushing, stomach cramp, and severe headache. So he has taken alcohol along with a nitroimidazole, that is metronidazole or fexinidazole or tinidazole, whatever it is. But for sleeping sickness, we give fexinidazole. So what could be the reason for the condition? So all these symptoms go in favor of disulfiram-like reaction. So let's see first option, just a normal alcohol-induced side effects. No. Due to sleeping sickness, no. Sleeping sickness does not cause these kind of symptoms. So wrong. Caused by fexinidazole interaction with alcohol. Yes. This is a side effect that is noted and the precaution should be taken. You should never drink alcohol when you are taking nitroimidazole group of drugs. Both 2 and 3, it's not correct. So the correct answer will be caused by fexinidazole interaction with alcohol. So let's see now, quick peek about disulfiram-like reaction. So if you see here, ethanol metabolism, usually the ethanol is getting converted to acetaldehyde and then to acetate. The ethanol is getting converted to acetaldehyde by what? By alcohol dehydrogenase enzyme. Acetaldehyde to acetate by acetaldehyde dehydrogenase. So there are 2 enzymes involved. Ethanol to acetaldehyde, acetaldehyde to acetate. First is alcohol dehydrogenase, so acetaldehyde is formed. Second is acetaldehyde dehydrogenase, acetate is formed. Then it enters the cycle and it is getting converted again. So one drug that can block the alcohol dehydrogenase enzyme is fomepizole. This is not available in India, only in USA it's available. It is used for methanol poisoning. Remember this, FDA approved for methanol poisoning. The second drug that can inhibit is disulfiram. That's why you call it as disulfiram-like reaction. So disulfiram. So what are all the drugs that cause disulfiram-like reaction? Remember CGMP. Okay, first is chloramphenicol. Then comes your chlorpropamide. Even tall butamide can cause. So chlorpropamide and tall are anti-glycemic, hyperglycemic drugs. Chloramphenicol is an antibiotic. Then comes your cephalosporins. Cefaperazone, cefamandole, and cefotetan. 3 cephalosporins. Chloramphenicol, chlorpropamide. Then comes your cephalosporins, cefaperazone, cefamandole, and cefotetan. The last one in C is your carbamates, that is your OPC. That can also cause disulfiram-like reaction. So C is over, cyclic. Now G, antifungal drug, graziofulvin can cause this. Remember, graziofulvin can cause this. For M, easy. You have your metronidazole, which is nitroimidazole group. So all the three drugs, nitroimidazole, fexinidazole, tinidazole. Even if you don't remember this F, a friend of metronidazole is fexinidazole. Teacher of metronidazole is tinidazole. Simple. Then for P, it is procarbazine. So ethanol, acetaldehyde, acetate, alcohol dehydrogenase, aldehyde dehydrogenase. Alcohol dehydrogenase, first step, fomepizole, used for methanol poisoning, FDA approved, not available in India. Then second step, disulfiram. That's why you have disulfiram reaction. What all drugs that can cause disulfiram-like reaction? CGMP is a mnemonic. Chloramphenicol, anti-glycemic drugs, that is chlorpropamide and tolbutamide. Then 3 cephalosporins, cefotetan, cefomendol, and cefoperazone. Then comes your carbamates, that is your OPC. Then G for antifungals, graziofulvin. M, metronidazole, a friend of metronidazole is fexinidazole, a teacher of metronidazole is tinidazole. Then moxalactam, this is one antibiotic. Moxalactam can also cause disulfiram-like reaction. The last one is P, procarbazine. So this is a very important 2 topics I have taken today. In spite of new drugs, I have also covered disulfiram reaction and drugs causing it. Either one question you can expect from this topic. Definitely, I am expecting a question. So please revise my slides and make sure that you answer the questions properly. Okay, that's it for today's class. We'll meet tomorrow with another set of new drugs. Thank you.
So good evening, everyone. So today we'll discuss about 2 important topics. One is stromsconoid. We'll also discuss about retinoscopy and a few points about synaptophore. Okay. So first, let's start with stromsconoid. What is stromsconoid? So remember the configuration of the light as So what is stromsconoid? The configuration of the rays of light as they travel through a toric surface or an astigmatic surface is known as the stromsconoid. So the configuration of the rays of light as they travel through a toric surface or an astigmatic surface is known as the stromsconoid. Okay, stromsconoid, we have to remember that in the astigmatic meridians there are 2 meridians. Okay, there are two meridians. One meridian is known as the principal meridian. So what is the principal meridian in a toric surface? The principal meridian is the one which has a the principal meridian with the minimum power and the minimum curvature. Okay, the minimum power and the minimum curvature is known as the base curve. So they can ask you what is a base curve in a toric surface. So a toric surface has 2 meridians, one with a higher power, one with the lower power. The one with the lower power, the minimum power and the minimum curvature is known as the base curve of the astigmatic or a toric surface. Next, we should know about the configuration of the rays of light as they travel through the stromsconoid. So first point, what we see a horizontal oval. So what is happening at point A? So at the point A, the vertical rays are converging more than the horizontal rays. Okay, so the convergence of the vertical rays is more than the horizontal rays. This is point A. So point A, we see it as a horizontal oval. We see the point A as a horizontal oval. So next, point B. So point B, what happens? Point B, the vertical group of rays which are converging come to point focus. Okay, so the vertical group of rays, they come to a point focus. The horizontal group of rays are still converging. The horizontal group of rays are still converging. So this is seen as a horizontal line. This is seen as a horizontal line. Happening, the point C, the vertical rays after converging, they start diverging. So the vertical group of rays are diverging and the horizontal group of rays are converging. Okay, but the divergence of the vertical rays is less than the convergence of the horizontal rays. So the divergence of the vertical rays is less than the convergence of the horizontal rays. So this again is seen as a vertical, this is seen as a horizontal oval. Okay, the next is the point D. So point D, what is point D? The point D is the point where the divergence of the vertical rays is equal to the convergence of the horizontal rays. So the divergence of the vertical rays is equal to the convergence of the horizontal rays. This is known as the circle of least diffusion. Circle of least diffusion. Okay, so what is the circle of least diffusion? This is very important. Circle of least diffusion is the point where the divergence of the vertical rays is equal to the convergence of the horizontal rays. Next is point E. So in point E, what is happening? The divergence of the vertical rays is getting more than the convergence of the horizontal rays. So the divergence of the vertical rays is more than the convergence of the horizontal rays. So this again is seen as a vertical oval. So next, point F, what happens? Point F, the horizontal rays come to a focus, the vertical rays are diverging. Okay, so the horizontal rays come to point focus while the vertical rays are continue to diverge. They are continuing to diverge. So last point, point G, what happens? There is divergence of both the horizontal and the vertical rays. Okay, divergence of both the vertical and the horizontal rays. The divergence of the horizontal and the vertical rays produces a prolate ellipse. This is known as the prolate ellipse. Okay, prolate ellipse. So 2 points are very important in Stump's conoid. One is the circle of least diffusion, the point where the divergence of the vertical rays is equal to the convergence of the horizontal rays. The second point is the distance between B and F. Okay, so the distance between B and F is known as the Stump's interval. Okay, this is known as the focal interval of Stump's. Focal interval of Stump's. So I'll quickly repeat. Stump's conoid is the refraction of the rays as they pass through the toric surface. The toric surface will have two meridians. The meridian with the lower power and the lower curvature is the base curve, and the point D is very important. The point D is the circle of least diffusion, where the convergence of the horizontal rays is equal to the divergence of the vertical rays, and the focal interval of Stump's is the point between the horizontal and the vertical rays coming to a point focus. That is the focal interval of Stump's. So this is the Stump's conoid. Stump's conoid, again, they can ask you, they have asked previously and they can ask you questions. So this is very important topic. The next very important topic is the Jackson's cross. Okay, so this Jackson's cross, remember, it is used for the objective verification of the refraction. Sorry, this is used for the subjective verification of the refraction. What is the difference between subjective and objective? So for objective verification, the patient will see and tell if it's clear for him. Okay, this without the patient telling, if you want to confirm it, it is the subjective verification of refraction. So the Jackson cross is used for the subjective verification of refraction. Okay, it consists of a spirocylinder. Basically, it consists of two cylinders in the opposite direction placed at 90 degrees to each other. It consists of two cylinders, same power with opposite direction, placed at 90 degrees to each other. Okay, so basically, when you do the transposition, you get a spirocylinder. In the Jackson's cross, you get a spirocylinder. So what is the principle of the Jackson's cross? It has one spherical component and a cylindrical component. The spherical component is 1/2 of the cylindrical component. Okay, remember, the spherical component in a Jackson's cross is 1/2 of the cylindrical component. So usually, if it is 0.5 sphere, you will have a +1 diopter cylinder. Okay, so this sphere component is 1/2 of the cylindrical component in case of a Jackson's sphere. Okay, so it is, what are the uses of the Jackson's cross? It is used to verify both the strength of the cylinder and the power of the axis of the cylinder. Okay, it is used to verify the strength, power of the axis of the cylinder. Okay, so this is your Jackson's cross. Next important we should know is the retinoscopy. So remember, the retinoscopy can be done either with a streak retinoscope or it can be done with a a mirror retinoscope. Nowadays, we don't use mirror retinoscope. Everything is done from a streak retinoscope. So if we are using a mirror retinoscope, the source of light will come from behind the examiner. The source of light will come from behind the examiner. Again, the movement of the images are opposite when it comes to the mirror retinoscope and the streak retinoscope. So now we'll be discussing about the streak retinoscope. Okay. So streak retinoscope, if there is no movement on the streak retinoscope, it indicates the patient has a 1 diopter of myopia. So just now what we discussed in Jackson's cross. So Jackson's cross is for subjective verification of the power and the axis of the cylinder. Okay, the power of the cylinder and the axis of the cylinder is subjectively verified by the Jackson's cross. Okay, if you want to subjectively verify the spherical and the cylindrical component, we use the streak retinoscope. So the streak retinoscope is used for the subjective verification. So on the streak retinoscope, if you don't have any movement, it indicates a 1 diopter of myopia. If it moves along the movement of the light reflex, along the direction, then it means the patient has myopia of less than 1 diopter. It can also move in patients with emetropia. It can also move in patients with hypermetropia. Okay, so along the direction, myopia less than 1 diopter, patients with emetropia, patients with hypermetropia. If it moves opposite direction, if the movement of the movement is opposite to the direction of the movement of the streak retinoscope, then it indicates a myopia of more than 1 diopter. So more than 1 diopter myopia has a movement in the opposite direction. Okay, so this they have been asking questions, so you should know. No movement in myopia of 1 diopter, movement along the direction less than 1 diopter myopia, emetropia and hypermetropia. Movement in the opposite direction, then it is more than 1 diopter myopia. So quickly we'll go through the questions. Okay, so this is an AIMS question. The retinoscopy is done at a 0.5 diopter myopic patient at a distance of 1 meter. So movement of the image will be. So what did we discuss? So whenever you're doing a retinoscopy, we also always have to take two points of this one. So we have to take the distance correction. We also have to take the drug correction. Okay, so distance correction, if the distance is done, if the retinoscopy is done at a distance of 1 meter, the distance correction is 1 divided by 1 by focal length is the dioptric power. So we have to subtract 1 diopter if it is done from the distance of 1 meter. So if it's done at a distance of 2/3 meter, so 1 by focal length will be 3/2. So we have to subtract about 1.5 diopters. Okay, so if the retinoscopy is done at a distance of 1 meter, we have the distance correction is 1 diopter. If the retinoscopy is done at a distance of 2/3 meter, the drug correction, the distance correction is 3/2 or 1.5 diopters. Next is the drug correction. Again, depending on the drug we use, the correction is changing. For atropine, it is 1. Okay, so what drug correction for atropine is 1. Okay, so what did we just now discuss? For myopia less than 1 diopter, the movement is with the movement of the mirror. Okay, it moves with the movement of the mirror. Okay, so this is the retinal reflex which moves along the movement of the mirror. Okay, so on performing refraction using a plane mirror on a patient who has a refractive error of 3 diopter sphere, 2 diopter cylinder at 90 degrees. So this patient has -3 diopter sphere and -2 diopter cylinder at 90 degrees from a distance of 1 meter with no cycloplegic refraction. The reflex would be seen to move. So it will, again, what did we discuss? It is more than 1 diopter myopia, and again both in the horizontal and in the vertical, it is more than 1. So both directions it will move in the opposite direction. So the movement will be in both the horizontal and in the vertical meridian. The movement will be against the direction. Okay, movement against the movement in both the axes. So this is another important question. Okay, so with this we'll finish the class for today. So tomorrow we'll be discussing another very important topic, namely the named cataracts. Okay, so the named cataracts, all the named cataracts, the metabolism involved and the disease causing the named cataracts is very important for tomorrow's class. Okay.
So good evening, all of you. I'm happy to meet you all today again in another very short session on the cardiovascular, changes in pregnancy. And yesterday we had studied about the respiratory system changes, and the day before we have talked about the cardiovascular changes. So today again, another very important topic in the physiological changes, that is hematological changes. We are going to talk about hematological changes, also about coagulation also. Fine. So before we go into the topic proper, we'll have a small preview of all the questions, and you will definitely get an idea of what is being asked. Okay. So here is a question which is asking this: which of the following is increased in pregnancy? Is it platelets or clotting time or ESR or factor 11? And we have another question which says the clotting factors are definitely elevated in pregnancy. When will it come back to normal? That is, how many weeks after delivery will it come to normal? So that is a question. And another question on physiological changes in pregnancy, where something about serum fibrinogen, again something about clotting time, this ESR, you can see this point, what happens to ESR keeps coming in questions again and again. And it also focuses on two important factors, it is 11 and 13, whether they decrease or not. Similarly, another question on clotting factors, and this is a combination question, like something about hemoglobin, something about the cardiac output, something about peripheral vascular resistance, blood viscosity. Okay, so this is a question on the hematological changes and cardiovascular change put together. So we have 5 questions to be dealt today, and I think it's time we'll go into the topic proper. So when we talk about hematological changes, the first thing that I want all of you to understand is this concept of physiological hemodilution. So what is this basically physiological hemodilution? You should know that there is a disproportionate increase in the plasma volume and RBC volume. Okay, now plasma volume increases by 40 to 50%. Let's take it as half, okay, 50%. This RBC volume, on the other hand, increases by 20 to 30%. 20 to 30% increase. Okay, but when we take hemoglobin, so when we take hemoglobin, it's something like this. Hemoglobin increases by 18 to 20%. So actually hemoglobin increases. Okay, so before we go into this concept, we first finish off this concept. Okay, so there is a disproportion between the increase in the plasma volume and the RBC volume. So now this leads to dilution. Now this leads to dilution called physiological hemodilution, or you can even say physiological anemia in pregnancy. So the blood becomes more diluted, physiological hemodilution. See, though hemoglobin actually increases by 18 to 20%, when we talk about hemoglobin concentration, now this definitely decreases because of all the dilution. Now this physiological hemodilution, is it beneficial in pregnancy or is it detrimental? See, you cannot say a single answer to this question. Both, it does both. See, it is beneficial in that, what is the advantage of physiological hemodilution in pregnancy? This is equal to dilute blood. Okay, so the blood becomes more diluted. Which leads to decreased blood viscosity. Okay, so blood viscosity decreases means definitely it helps to increase the perfusion, especially through the uteroplacental sinuses. Okay, so increased perfusion through uteroplacental sinuses. So that's a very big advantage. Not only that, we have another advantage of this physiological hemodilution. The amount of blood is more when compared to the non-pregnant state. So this basically compensates for the blood loss during delivery. So compensates for blood loss during delivery. Okay. Okay. So that is the advantage. But there are disadvantages as well. So what do you understand by this? Even though the hemoglobin increases, it's definitely going to lead to anemia because of the hemodilution. So here anemia becomes inevitable. Inevitably, there will be anemia in pregnancy or hemoglobin dilution in pregnancy. So anemia becomes a common thing in pregnancy. So please understand the concept of hemodilution. So when we talk about all the Components like RBC, WBC, and platelets, we have just now studied that RBC will increase. So how much is the increase in RBC? It is around 20 to 30%. But invariably, it leads to anemia because of dilution. All these concepts you know. What happens to WBC? It also increases. Percentages are usually not described. Okay, it also decreases. And there is more of increase in neutrophils, and it is neutrophilic leukocytosis. So increase in WBC alone cannot be taken as a marker of infection in pregnancy. So that's a big disadvantage of this point. What happens to platelets? No change. Usually in platelets, we don't have any change. But in 15% of pregnant women, just in 15% of pregnant women, there can be a decrease in platelets. And this is because of increased platelet consumption. This is because of increased platelet consumption. The decrease is not because of the decrease in production, because of increased platelet consumption. And this is called gestational thrombocytopenia. Okay, and this is a normal phenomenon. This occurs in 15% of pregnant mothers. So this is gestational thrombocytopenia. And please remember here, platelets will never ever go less than 1 lakh. It will never ever go less than 1 lakh. Now that's a very, very important point to note here. Is that understandable? See, we have more causes of thrombocytopenia in pregnancy. There are so many causes of thrombocytopenia in pregnancy, like say it can be HELLP syndrome. It can even be severe preeclampsia, right? It can be a disseminated intravascular coagulation. It can be ITP or other causes of thrombocytopenia. But if in exam you have a question like, what is the most common cause of thrombocytopenia in pregnancy? What is the most common cause of thrombocytopenia in pregnancy? Then your answer will be gestational thrombocytopenia. Is that okay? Okay, so now this is very, very important. Okay, now let's go to the next important point, like proteins. See, in pregnancy, the hepatic production of the proteins is increased. So hepatic production, you will see thyroid binding globulin, what happens? It increases in pregnancy. Cortisol binding globulin, what happens? It increases in pregnancy. So all the proteins that are produced by the liver will show an increase. But when let us say total proteins increase. But you see the word concentration, then definitely it falls no because of hemodilution. So whenever you see this word concentration, you can blindly write definitely it decreases, okay? Total protein concentration decreases, that's because of the hemodilution. When we take albumin and globulin, this albumin shows a slight fall, and the production of globulin shows a slight increase, which causes a reversal of albumin globulin ratio when compared to the non-pregnant state. So there is a reversal of albumin globulin ratio. So what is albumin globulin ratio non-pregnant state? It is 1.7:1. Now this gets converted to what? 1:1 at term. Now this is a question which comes repeatedly in exams. So please remember, the question may be, what is the albumin globulin ratio at term? They will ask like that, or they may ask from what ratio it becomes 1:1, like that. So this is very important. Okay. And also remember that ESR, so this point on ESR also keeps coming again and again. ESR increases by how much? 4-fold. Not only that, there is an increase in C-reactive protein also. It is said that also increases to around 4-fold. Complement C3 and C4 also increases. Please note, so many things which are markers of infection and inflammation are not useful in pregnancy because they normally rise because of a pregnancy. It's like your WBC count is also going to increase, ESR is also going to increase, C-reactive protein is going to increase, complement C3 and C4 are going to increase. So you cannot take all these factors, all these parameters as markers for inflammation in pregnancy. So that is the message here. Okay. So please remember all this because they come repeatedly in one or the other options in your questions. So is that okay? Now let's go to the coagulation part. coagulation part, we all know this point that pregnancy is a hypercoagulable state. So what do we mean by this hypercoagulable state? It says that there is increased predisposition to deep vein thrombosis, not only to deep vein thrombosis, but also to pulmonary embolism in pregnancy. So it's a hypercoagulable state. That is because basically there is an increase in clotting factors. So we will take clotting and we will take clotting factors. Okay. The most important point in this clotting factor is, first we will talk about factor 1. We all know factor 1 is, we all know that factor 1 is fibrinogen, right? Now this factor 1, fibrinogen, shows a increase which is the highest of all. Okay, so fibrinogen increases by around 50%. So this is a very important question in the exam. It increases to around 50%. So if you take normal fibrinogen level, say it's around 200 to 400 milligrams per deciliter. So maybe we will take it as 300. The mid value we will take. So in a non-pregnant state, the fibrinogen value, say it's around 300 milligrams per deciliter. How much does it become in pregnancy? 50% increase. So it becomes 600 milligrams per deciliter. Now, is that understandable? So fibrinogen shows the highest rise. When we talk about the other factors, 1, so we'll include this one, 7, 8, 9, and 10. All these factors show an increase. Okay, all these factors show an increase. And please remember, factor 2, 5, and 12. 2, 5, and 12 show no change. And there are 2 factors in pregnancy which will decrease. This is factor 11 and factor 13. So factor 11 and factor 13 will decrease in pregnancy. And so many times questions will come on these clotting factor levels. And this is a question which is often repeated, like what are the 2 clotting factors which decrease in pregnancy? It is 11 and 13. Now, I think it's time for us to talk about the coagulation inhibition. So when we take coagulation inhibition, it is protein C and protein S. Protein C and protein S. Protein C actually shows no change, but there is a decrease in protein S. Now, if we take fibrinolysis, it is said that plasminogen activator inhibitor levels will decrease. So what happens when plasminogen activation increases? That means blood is not fluid. Okay, blood is more. There's more chances that the blood will clot. Okay, so plasminogen activator inhibitor increases. Now, in spite of all these changes, please understand, in spite of all these changes, the common laboratory investigations surrounding coagulation, like the bleeding time, clotting time, prothrombin time, activated partial thromboplastin time, shows no change in pregnancy. You cannot claim that this will increase by this many times. No, there is no change. The state is a hypercoagulable state, which says that if she has predisposing factors, then there is more chance of developing a DVT. So that's the only point we need to understand. Okay, now the other important question that's commonly, when does this hypercoagulable state come to normal? Okay, so this elevated clotting factors and the hypercoagulable state returns to normal 2 weeks after delivery. Okay, returns to normal 2 weeks after delivery. Now, this is also a very, very important question for us in the exams. Fine, okay. So I think we have done justice to all the points, most important points. And this return to normal, I just want to add some points on this return to normal because they come as questions. When does the HCG level come back to normal? After delivery, it is 2 weeks. Clotting factor, I told it is 2 weeks. Cardiac output, when does cardiac output come back to normal? We had studied all that. It will come back to normal in 4 weeks. Okay. Similarly, uterus was a bigger organ. When uterus will become an intrapelvic organ after delivery, please understand that is also 2 weeks. When uterus will come back to the complete pre-pregnant state, or if it is asked, when is complete involution of uterus? So complete involution of uterus will take 6 weeks, which is the period of puerperium. So all these are questions. So thank you all for your patient listening. Now we'll go back to the 5 questions which we have seen. It will be very easy to solve. Which of the following is increased in pregnancy? Platelets, clotting time, ESR factor 11. It is ESR, increases by 4-fold. Elevated clotting factors return to normal 2 weeks after delivery. Which of the following statement is false regarding the change? We'll see serum fibrinogen increases, yes. Clotting time increases, no. ESR increases, yes. Factor 11 and 13 decrease, yes. So the odd man out is B. The clotting factor that is decreased in pregnancy is 11 and 13, so our option is C. All of the following are seen in pregnancy except increased cardiac output, yes. Decreased peripheral vascular resistance, yes, because of progesterone. Increased hemoglobin concentration, no. Decreased blood viscosity, yes. So your answer is C. So after we learn the points, the questions become very easy and they become very simple. So thank you all for your patient listening, and we have done with cardiovascular changes, respiratory system changes, and hematological and coagulation changes. I'll meet you all with tomorrow with all other miscellaneous small changes in pregnancy, the skin changes, okay, the dermatological changes, the GIT changes, the renal changes, and all hormonal changes. I'll meet you tomorrow by the same time. Thank you all for your patient listening.
Hi friends. Good evening friends. Today we will be discussing a very awesome question where the love for radiology will start from you. Today's question is, a baby playing with toys and coins was left unattended by the mother. It started developing distress. A regular chest radiograph and lateral view are taken to confirm the location and to decide further management. Friends, first I will decode the question for you. Today, our radiology topic will be foreign body, which will be ingested by the baby orally. Okay, so here the question is, a baby playing with toys and coins was left unattended by the mother. Okay, whenever a child is left unattended by the mother, what happens? It leads to some sort of problem. Okay, here the baby started developing distress. A regular chest radiograph. Always remember, a regular chest radiograph means a regular PA view. Okay. In case of baby, what we call is In case of baby, what we call is, it is called babygram image. Okay. So what does babygram mean, sir? Babygram means whenever a pediatrics baby comes to us, a pediatrics baby or a pediatrics child, what we will do in radiology, we will cover both the thoracic cavity as well as the abdomen. That is called a babygram image. Babygram image is X-ray, a radiograph of the thoracic cavity and abdomen combined together. Okay. A regular chest radiograph means PA view. Okay. If the baby is non-cooperative, we can also do a AP view, okay, and a lateral chest X-ray. Whenever you are given a lateral chest X-ray, okay, of the same location, that means in AP view, I mean in the first view, you are getting certain details, and in order to further know details, you are taking a lateral view, okay, friends. The question is, where is the coin located? The given options are esophagus, trachea, lungs, and stomach. So from these 4 options, esophagus and stomach are GIT, trachea and lung are respiratory system. Okay. So the concept behind the question is, the child has ingested the coin, whether the coin has entered the respiratory system or it has entered the GI, gastrointestinal system. That is what the question is. Here, first I will give you the correct answer. The correct answer is esophagus. Okay, for coin lodged in neck, and it is esophagus. Then it will be seen in face on frontal AP view. Friends, what you must understand is, what is the description given here is, the coin will be in face. That means in face means the face of the coin, right? This is how our Indian coin will be, right? The 3 lines will be there, no? That is in face view on frontal. Frontal means straight AP view. That is broad in transverse dimension. The coin will appear broad. Okay, that is what is given here. I will explain to you in very detail. Friends, what you must understand is, let's have a quick review of anatomy here. Okay, let's say a child swallows a coin. The coin enters through the mouth, then the oropharynx, then it goes towards the esophagus in case of gastrointestinal tract. Okay, in case if the coin enters through oropharynx, then the pharynx, larynx, that is the voice box, then it enters trachea. Sometimes it can enter, okay, it can enter the trachea and it can dislodge into the bronchi level. So these are the 2 things which we must consider. Here, by nature, the thing is, remember this concept, core concept, okay? Esophagus will be always in a collapsed state. So, whenever a coin enters through the esophagus, the coin will be like this, okay? It will be broad appearing. In a radiograph, it will be broad appearing. In case of respiratory system, if the coin enters the trachea, no. If the coin has to enter the trachea, it has to enter through the larynx. Okay, larynx voice box will be like this, friends. Remember this. This is very important. Will be like this. So if a coin has to enter, it will enter in a side view. Okay, let's say this is the coin. If the coin has to enter through the trachea, it will enter like this, side view. If it enters the esophagus, it will be like this. That is the core difference here. Okay, you should remember it. Next thing, that is what I have said. In case of trachea, the thing, what is the thing is, it will be appearing in profile view. That is, it will be appearing in a side view if it is in the trachea. That is, it will be like a slit-like and better appreciated on lateral view. So what they are coming to say is, now, first I will clear about esophagus. Okay, the child swallows the coin. The coin will be like this in a frontal radiograph. Okay, let's say now we take a lateral view, friends. Remember lateral view, the coin will be side, it will be appearing from side, right? So that is what is given in the image. The first image is the coin is appearing like this. In the side lateral view, it is appearing in a side. The entire opposite is for trachea. Look at this first image clearly. In the second image, see the coin is like this, side view. In a normal frontal radiograph, and it will be better appreciated in a lateral view. The coin will be appearing broad like this. Okay, this is purely because of the anatomy. Since the larynx is very narrow, the coin will be side. Normally it will be side. When we take a lateral view, it will be appearing broad. Okay, sir. Sir, whatever you explained feels good, but can you tell me some mnemonic? How to remember it easily? Very simple. I will tell you one concept. Just remember the two words, esophagus and trachea. Okay, and remember, always we will do a frontal radiograph, right? Frontal means straight. Esophagus, how is the first word? It is round. So the coin will be appearing round. Okay, in frontal radiograph. In case of trachea, look at the word T. So the coin will be appearing like this in case of frontal radiograph. Simple. Just remember this thing. In case you understand what I told earlier, that is far better for you. If you understand this, this is enough for your level. Okay, sir. Let's go to INICET level. In case of INICET level, you have to dig a little bit deeper. I will tell you about the further informations. First of all, foreign body aspiration is most commonly seen in children. So it is in pediatrics age group below 4 years of age. Okay, this has been asked one time in question. It is sometimes seen in adults also. When, sir, that condition is called cafe coronary syndrome. So what is cafe coronary syndrome? This is forensic medicine. I will discuss with you. Let's say a male, he consumes lot of alcohol. So what happens, physiology, his deglutition reflex will be depressed. Okay, what happens, he's going to a restaurant and he's taking chicken, he's nicely eating chicken. He's eating a bone, not boneless chicken, bone chicken. So what happens, since his deglutition reflex is depressed, this the bone will not pass the esophagus and it will get occluded. That condition is called cafe coronary syndrome. Okay, cafe coronary syndrome means it is fatal condition. It is a very rare condition, but it can happen. Food asphyxiation, the food particle getting dislodged in the respiratory tract and causing asphyxia. Okay, can lead to death. I have given you the definition of it. Cafe coronary syndrome is a condition in which a healthy person who begins a meal suddenly collapses and dies without any further distress. It happens very sudden, friends. Okay. Signs of choking are absent, and cause of death is reflex vagal inhibition of the heart. This mechanism has been asked as a question. In case of Cabet coronary syndrome, what is the mechanism of action of death is reflex. Okay, the reflex pathway, vagal inhibition of the heart. Cabet coronary syndrome. Okay, now I will ask you another question. See, let's say as a doctor, you are sitting in a restaurant, you are happily enjoying the food along with your friends and families. That time you saw a male, let's say a depressed male, he has consumed a lot of alcohol and he is suffering from choking because of the same condition, Cabet coronary syndrome, fatal food asphyxiation. What will you do? The treatment, let's say the treatment of choice in this case is, that is a gold standard question, anesthesia, Heimlich maneuver. Okay, I think many will be known about this term. What is Heimlich maneuver, sir? From the back, what you have to do is you have to bend the patient, and from the back you have to tap him. Just give a rapid blow. 10 times you give rapid blow, followed by that, put a hold like this below the sternum, stand behind, and press from here, press forcefully. So what happens, whatever the food has entered, no, it can dislodge. That is like a first aid, and call 108 and follow it afterwards. Okay, call ambulance. So this is what applied radiology, friends, in that case. I have summarized everything for you. Just to look, I will just detailedly explain you. Whenever a patient comes with foreign body, chest radiograph is the first investigation to be used, and it should be combined with the abdominal radiograph. Remember what I told you earlier? Chest radiograph with abdominal radiograph. In case of pediatrics, patient is called a babygram. Okay. Also, as many times the child may cough up the foreign body and immediately swallow it. Okay. So what happens? We have to do a serial of X-rays followed by that. Why, sir? Because let's say the foreign body is in the GI tract, esophagus. The patient is coughing, so it can come and it can enter the respiratory tract, or vice versa. It can be in the respiratory tract, trachea, and by coughing, rapid coughing, it can come to the oral cavity and the child can swallow it. That's why what we should do is we should do a serial of radiogram, frontal view and lateral view, to find exact location of it. In case of pediatrics baby, most common foreign body to be aspirated is peanuts. It has been a question in the past. Hence, in a suspected foreign body obstruction, expiratory radiograph should be obtained. So what is expiratory radiograph? Ask the patient to expire the air possible, and then take a radiograph so that air won't be inside. And you will know, because of the foreign body obstruction, air can be trapped inside. That air you can see, since we are asking the patient to expire completely. Findings on a chest radiograph include hyperinflated lung. How it will appear? It will appear dark because there is obstruction, air is trapped. You have asked the patient to expire out completely, so the trapped air will be appearing hyperinflated dark. Radio opaque foreign body may be directly visualized. It will be radio opaque. In such cases, a PA and lateral radiograph will be helpful for exact localization. The orientation of the structures in the body also helps when single view is available, like for a coin lodged in neck. If it is in esophagus, then it will be seen N face on frontal. As I told you, esophagus, O, N face. View that is broad in transverse dimension, while if it is in trachea, it will appear N profile, trachea T, it will appear side, it will be appearing narrow in a frontal radiograph. Okay, friends, and here I have given you the same diagram. So now tell me, the first diagram is esophagus, okay, the second diagram is trachea. Okay, now let's say you have find out that there is a foreign body present, and let's say it's in the respiratory tract. How will you proceed further? It's pulmonary medicine. The thing is, follow up with bronchoscopy. Bronchoscopy is considered the gold standard. What is gold standard in case of foreign body aspiration is bronchoscopy. It is the diagnosis and management of tracheobronchial tree foreign bodies. Okay, remember it. In all suspected case of foreign body obstruction who have evidence on imaging or show no improvement or deterioration clinically should undergo bronchoscopy for confirmation and removal. This is what, with this we are coming to a completion, and here I have given you the diagram, friends. What is this? This is how a pulmonary medicine specialist will be doing a bronchoscopy. He will be putting a probe into your trachea and bronchi and finding what is lodged there and helping you remove it. Okay, friend. So today with this question has been asked in the past. It is a potential MCQ because the nature is so much created that the trachea and the esophagus anatomy has made the coin to look like that. It's a fantastic question. If I set a question paper, surely I will add this question. It's a very basic question, repeated lot of time. You have to be very thorough with this. Thank you, friends. With this, we are coming to the end of the question. Have a good day. Thank you.
Hello, am I audible? Can I just get a confirmation if I'm audible, please? Okay, thank you. Hello, everyone. I'm Dr. Sneha. Today, we'll be dealing a little bit about the topic of aneuploidy screening from fetal medicine. Now, fetal medicine itself has become a very important subspecialty in obstetrics because it has helped us to diagnose and also to treat certain genetic and fetal conditions that were thought to be untreatable in the past. Okay, so let's look at it briefly. So what does it mean? What does fetal aneuploidy screening means? Basically, you're telling the patient, what are your chances of carrying a baby with trisomies? Especially trisomies 21, Downs, 18, Edward, or 13, Pathaus, okay? So these are the main problems that you can tell the patient. You're not telling her an exact yes or no answer. You're just giving her a chance. Are you at a high risk or low risk of carrying a baby with such condition? Okay. And whom do you offer the screening to? You can offer them to all pregnant women. Counsel them in the first trimester itself when they come for the first checkup that there is a test like this which can help you to find out if your baby is at risk of having these genetic problems. Okay, so you can offer them to all, including patients carrying twins. Okay, but you cannot offer them to patients carrying multiple pregnancies, that is triplets and above. Okay, so in these cases, they have not been found to be very effective or sensitive to find out. So you can offer them to everybody. Remember that these are just screening tests. Like I said below, all they can say is they can tell you if the patient has high risk or low risk of developing these aneuploidies. The baby is having this aneuploidies. It does not tell you for sure whether the baby is actually a Downs or Edwards or Pathaus. So if the patient's screening test comes back as high risk, you have to offer her a diagnostic test to confirm that the baby actually has such genetic problem. Okay. Now, what are the different types? What are the different types or different things that you can look at to guess if that patient has a baby that might have risk of having genetic problem? First is age of the patient. Now, as the patient ages, especially when the age crosses 35 years, there is a chance that when every month an egg or an ovum is formed, okay, there can be non-disjunctional meiosis happening. So there'll be a faulty egg, which can lead to trisomies. But now Just with age alone, you cannot tell the patient whether she has an increased risk of developing trisomies, because it has been found out that more than 70% of patients less than 35 years are found to have Downs. Let me rephrase that sentence. More than 70% of cases of Downs, if you look at the age of the patient, they'll be less than 35. But if they are more than 35, it is a indication that, or you can tell her that compared to the rest of the pregnant population, she is at a slightly higher risk of developing trisomies, babies with trisomies. But because the detection rate is very less, age as such, age alone cannot be used as a standalone test to do a screening test. The next is nuchal translucency test by using ultrasound. Okay, nuchal translucency is a scan in which you measure the amount of fluid that is collected at the back of the baby's neck. And as the nuchal translucency value increases, higher the chance of having a aneuploidy baby. Okay, and in fact, if the nuchal translucency is more than 3 millimeter, you don't have to look at other tests. It is a direct indication that you have to go for a diagnostic test. It is very, very high risk that the baby might have aneuploidy. The third is by taking blood samples from the mother to look at some markers, some different chemicals, and to see if they are at a higher range or lower range. We'll look at them one by one. Usually this is done in combination with NT, okay, to give us a better detection rate. The fourth method is called as non-invasive prenatal test, otherwise called as cell-free DNA. And this is also a test that is taken from the mother's blood. Okay, and this can be used as a standalone test to detect if the baby has a higher chance of having aneuploidies. And let's look at them one by one. Coming to first trimester. First trimester aneuploidy screening test. Let's look at some of the first trimester aneuploidy screening tests. But when in first trimester, when do you offer these patients screening? You offer these patients screening between 11 to 13 weeks and 6 days in first trimester. Okay, this will be an ideal time for them to offer them this first trimester screening. What are the different options that are available? First is nuchal translucency. As we already mentioned in the previous slide, it is measuring the fluid that is collected at the back of the baby's head. So this is a sagittal view of the baby. If you can make out, this is the baby's head. You're seeing it from the side. The baby is lying down and you're seeing from the side. This will be the nose, the lips, and this is the thorax. And if you see this tract-like structure, this is the vertebral column at the back. Okay, and so now this is the fluid collection that is seen at the back of the neck, and this is what you measure as NT. Now you measure this NT, and just with this NT alone, the detection rate of whether the baby has aneuploidy or not is only around 60 to 70%. Okay, so now what they have done is they have introduced another test called maternal serum markers, which means that they will draw blood from the mother to look at two different types of chemicals in first trimester. First is they will measure the beta HCG level, and second is a chemical called as PAP-A. And in Down syndrome, beta HCG level will be elevated compared to normal babies, and in the PAP-A levels will be relatively low compared to normal babies. Okay, now maternal serum alone, if used, also has a lesser detection rate. So that is why what they have done is, or what they are recommending is to use a scan along with the mother's blood test, which is called as combined first trimester screening. So combined first trimester screening includes nuchal translucency along with maternal serum marker. And after doing all this, you will enter it in a software, and the computer will give you a risk. They will tell you, the computer will analyze everything and tell if the patient is at a higher risk or lower risk of having a baby with an aneuploidy. Now, when you combine both of this, the detection rate becomes as high as 80%. Okay, 80% of the cases you can detect if the baby is at a higher risk of having aneuploidies. All right. Now the next is second trimester screening. When in second trimester do you offer them? The ideal time to offer the second trimester screening is between 15 to 21 weeks. Okay. Now let's look at the types of tests that are available. The first is called triple test and the second is called quadruple test. Okay. Both of these are maternal serum testing. That means you take blood sample from the mother. In second trimester screening, there is no ultrasound component. It is just blood sample from the mother. And there are two types. First is triple test and the second is quadruple. Now let's look at the analytes that are seen in triple test. In triple test, you look at the level of beta HCG, and then maternal serum alpha fetoprotein and unconjugated estriol. These are the three analytes that you see. Now, if you add inhibin to the triple test, it becomes quadruple test. Okay. So all these three along with inhibin A becomes quadruple test. The reason they introduced quadruple test is because they have a much higher rate of detection of up to 80%. So this is almost similar to combined first trimester screening, their detection rate. Okay. So when can a second trimester screening can be done? The first use is it can be used as a test by itself. For example, if the patient comes for late booking at around 16 weeks. So she's interested to know what are her chances of having a baby with aneuploidy, but she can't have a first trimester screening now because she's crossed 13 weeks and 6 days, right? But she's in the right range. She's between 15 to 21 weeks, exactly at 16 weeks. So at this point, you can offer a second trimester screening, either triple test or quadruple test, to tell her what are her risks, what are her chances of having a baby with aneuploidy. The second use is you can do something called as an integrated test. Now, this is where the patient has already done first trimester screening and she says she wants to know, or she wants to have a test that has a better rate of detecting if she has aneuploidy baby or not. So what you can do is you can offer her first trimester screening. You don't give her the result. In the second trimester, you do quadruple test. And both of these will be entered in a computer and the computer software will give you a risk. So when you combine both first and second trimester screening, after the second trimester screening, you give her the result. This is called as integrated test. And the main advantage is that with integrated test, the detection rate becomes very high. Around 95% of cases you can detect for sure if they have a high chance or low chance of developing an aneuploidy baby. Okay. Now let's look at NIPT. NIPT is a relatively newer test. It stands for non-invasive prenatal testing, otherwise called as cell-free DNA. And this is also a test that is done by just simply taking the mother's blood sample. Okay. You don't poke the baby at all. The principle behind this is that the placenta of the baby releases some cells into the mother's circulation. Okay. If you're looking at exact word, they are apoptotic placental cells. So this is actually a misnomer. It is not fetal cells that you're looking at. You're looking at the placental cells, which indirectly will tell you what the fetal cell is like. So some amount of the placental cells goes into the mother's circulation, and you take the mother's blood to analyze the placental cells to find out if the baby has aneuploidy or not. Okay, so this is called NIPT or cell-free DNA. And when do you offer this test? This test can be done after 9 to 10 weeks, anytime after 9 to 10 weeks, because if you do it at less than this, the fraction of the placental cells that enter the fetal, the mother's body is quite less, at less than 9 to 10 weeks. That's why you wait for this gestational age. NIPT has an advantage compared to other first and second trimester screening. It has other uses as well. The first use is to detect aneuploidies, like rest of the screening. The other two uses is that it can also detect any sex chromosomal abnormalities, like hemophilia and other type of X or Y gene related disorders. And also because it can detect the sex of the baby, you can find out, suppose if the baby is, if you're suspecting congenital adrenal hyperplasia in a baby, and if the baby is XS, you can start treatment to the mother to decrease the amount of testosterone that is produced in the girl child. Okay, but this, because sex detection is prohibited in India, this is actually not a practical usage in our country, but please remember it can detect sex chromosomal abnormality as well. And the third use is it can find out the RHD status of a baby. Of, suppose if the mother is a negative blood group, you know that it can cause a condition called erythroblastosis fetalis if the baby is positive, right? So you can find out the RHD status of the baby to see if that baby requires monitoring and if the mother requires extra care. So these are the other uses. Now, screening test comes as high risk. What is the next step? The next step is you have to always confirm the diagnosis, because it is only a screening test. You need to do a diagnostic test, and that includes chorionic villus sampling, amniocentesis, or fetal blood sampling. All of these are invasive tests where you poke a needle into the mother's abdomen to either take a sample from the placenta, the amniotic fluid, or the baby's blood, and you analyze the fetal cell that you get from it and find out for sure 100% if the baby has any aneuploid. Okay, now let's quickly revise what we have learned. Let's look at the test and their detection rate. NT is nuchal translucency, and we know that the detection rate for aneuploidy is only around 60 to 70%. NIPT is non-invasive test, and this has the highest rate of 99.5%. Okay, a very, very high rate. In fact, the highest of all screening tests to see if the baby has aneuploidy. Combined first trimester screening is around 80%. And if you remember, even quadruple test is around the same 80%. And integrated test is combining both first and second trimester. And this has a detection rate of around 95%. Next question. Triple test, that is a second trimester testing, isn't it? Triple test does not include which of the following serum marker: unconjugated estriol, maternal serum alpha fetoprotein, beta HCG, and inhibin A. So if we remember, the first three is triple test, and if you add inhibin A to this, it becomes quadruple. So the answer here will be inhibin A. Now, quickly revise which of the following will be increased in quadruple test and decreased in quadruple test. We know that there are 4 serum analytes, right, in the maternal blood: alpha fetoprotein, unconjugated estradiol, inhibin A, and beta HCG. The analytes that decreases are unconjugated estriol and alpha fetoprotein. Okay, the analytes that increases are inhibin A and beta HCG, and this is for a baby with Down syndrome. An easy way to remember is dual BIB. Okay, D is for decreased, unconjugated estradiol, and A stands for alpha fetoprotein. L is just for remembrance, and BIB stands for increased, beta HCG, and inhibin A. Okay.
Good evening, everyone. Today, we are going to continue with our session from the molecular biology. And today, we will be talking about DNA polymerase, a very important enzyme which takes part in the DNA replication process. Okay. Now, DNA polymerase, as such, was first studied in E. coli. And in E. coli, the replication process takes over 20 enzymes and proteins to do the task of DNA replication. We will be talking focused upon DNA polymerase today. I will be just touching upon few of the other enzymes. Now, these over 20 enzymes and proteins which took part in the DNA replication process were called as replisomes. Okay, due to time constraints, we will talk about the important ones, focusing more upon DNA polymerase. Okay, now we know that we had discussed yesterday about topoisomerase. Yesterday's session, we discussed about topoisomerase. So, what are topoisomerase? These are, they help in relieving the torsional strain. That is, once your double-stranded DNA is unwinded, there is a supercoiling happening, and to relieve that torsional strain, you require a topoisomerase, and these are called as the nicking releasing enzyme. Right? Yesterday we discussed a lot about it, so I'm not going into it. The next enzyme is helicase. What is the function of helicase? It is helps in the unwinding of DNA, and it is ATP dependent. It is ATP dependent. It requires ATP. Our next enzyme is DNA primase. Now, DNA primase belongs to a class of DNA dependent RNA polymerase. Right? DNA dependent RNA polymerase, and they RNA primer. Okay, they initiate the synthesis of RNA primer. Okay, then we have binding protein, single stranded binding protein. What is the importance of this? They prevent premature annealing. They prevent premature annealing of the strands. They prevent it, the premature re-annealing of strands. Okay, then comes DNA polymerase, the enzyme about which we are going to talk in extensively today. Now, DNA polymerase helps polymerization Okay. So sorry for the technical issues. Okay, so we were talking about DNA polymerase. Okay, so it was first discovered by Arthur Kornberg in E. coli. Arthur Kornberg in E. coli, and that is why DNA polymerase 1 is also called as Kornberg's enzyme. Okay, now E. coli contains at least 4 other DNA polymerases. Okay, we won't be discussing about each of them. We will be discussing about the most important and most relevant ones. Most important and most relevant ones. Okay. Now, DNA polymerase. It requires a RNA primer. What is this RNA primer? It's a short strand. It's a short strand of the complementary template. Okay, so we were talking about the chain elongation process, and it deals with the number of nucleotides added per second. Nucleotide added per second. Now, for this, the enzyme has a specialized pocket with two regions. One is the insertion site, where the incoming nucleotides binds, and the post-insertion sites where the newly made base pairs reside when the polymerase moves forward. When the polymerase moves forward. Okay. Next, we come to processivity. The number of nucleotides added before dissociation is called as the processivity. That is, before the DNA polymerase is taken out of the strand, that is what is called as the processivity. Now, the processivity of polymerase in general varies widely from a few nucleotides to many thousands, right? And each specific polymerase has its own processivity. Like, for example, DNA polymerase 3. DNA polymerase 3 has a processivity of up to 100 to more than 50,000 nucleotides. Right? Now, the next is the proofreading capacity. Almost all DNA polymerases have an additional activity, almost all, I'm not saying all, almost all. And this activity is by the 3' to 5' exonuclease activity. Okay, proofreads the synthesis for mismatched base pairs. Now, translocation of the enzyme to the next position is inhibited until the enzyme can remove the incorrect nucleotide. So it is a foolproof method. Okay. Now, one additional thing that I would like to add here is the repair function. The proofreading is by the 3' to 5' exonuclease. The repair is by 5' to 3' exonuclease. Okay. So I told you in the beginning, if we go into the types of DNA polymerase, it's a very long session. I will be just touching upon the most important ones. Right now, first we will look at the prokaryotic DNA polymerase, and DNA polymerase 1 is the most abundant, but it is not the most ideal one. It can only incorporate up to 600 nucleotide per minute. Okay, so and the primary function of polymerase 1 is cleaning up. The primary function is to clean up. Okay, now before going to DNA polymerase 2, I will come to polymerase 3. Polymerase 3 is the principal replication polymerase. The principal replication polymerase. Okay, and along with polymerase 2, 4, and 5, polymerase 2, 4, and 5 are involved in the DNA repair. Coming to the eukaryotic side, in the eukaryotic side, we have again a long list, but we will be focusing mostly on the ones from which we can get a question. Okay, for DNA polymerase alpha have a primase and a polymerase activity. Okay, DNA beta have a high fidelity and is for repair. Right? Gamma is for mitochondrial DNA synthesis. Delta is for the lagging strand, and epsilon for the leading. Okay, now they also have the proofreading ability, and the proofreading is from 3' to 5'. Okay, along with DNA beta, zeta, and kappa also have a repair function. This is in the eukaryotic one. So let's try answering a question. False statement about DNA polymerase 3 is it is needed for replication, has proofreading function, forms Okazaki fragments, does not need a primer. Yes, you answered it correct. It does not need a primer is the wrong answer here, because it is needed for replication, has a proofreading function, forms Okazaki fragments, and it needs a primer for getting that 3' hydroxyl for the first reaction. So trying to wind up, and the most important points about DNA polymerase, the bacterial DNA polymerase, things that we can remember is, number 1, polymerase 3 is the main and the most required one for the polymerase activity. It is most processive. It polymerizes Okazaki fragments. Okay, and it synthesizes the leading strand. Proofreading activity in the bacterial one is done by 1, 2, 3. Okay, the repair activity is by 1, filling gaps is by 1. Okay, so DNA polymerase with both a replication and repair function, this is a very old question. The answer to this is 1. Okay, so we shall stop our session here for today, and you may continue to the next class. Thank you, all of you.
Yes. So welcome back to this particular video where we are discussing important questions from anesthesia and critical care. And if you remember our Monday's class, I had given an introduction to certain important topics in the ECG section. So as always, ECG is always an important hot topic for you in your entrance exam. You can get a variety of image-based questions and concept-based questions. So right now in this particular session, what I'm going to do is I'm going to give you an idea about rhythm analysis. Okay. So what am I going to do? I'm going to give you an idea about rhythm analysis. Now, I'm going to give you a simplified way by which you can start assessing the rhythm. I had given an introduction where I was discussing about tachyarrhythmias in the last class. Now I'm going to give you a wholesome perspective by which you will be able to identify and spot certain important rhythms. So I'm going to start with the basic. Let me just draw a symbolic heart here and let me just make you understand what is a normal QRS complex, normal P wave, etc., etc. Then I'll discuss three important set of rhythms: your sinus rhythm, your junctional rhythm, and your ventricular rhythm. Okay. So this is your heart. Okay. This is your heart, obviously. And you know that you have something which is called as the SA node here, right? And you have the AV node, bundle of His, right bundle branch, left bundle branch, and Purkinje fibers, right? This is how depolarization happens inside your body or inside your heart. So atrial depolarization is basically done by the SA node. So the depolarization vector travels from the SA node back into the AV node, right? So this is how normal depolarization of atria take place. And if you note here, there is anterograde activation of your atria. From the SA node to AV node, there is anterograde activation of the atria, and that is why you are going to get an upright P wave. Following which, the bundle of His, Purkinje fibers and bundle branches together will cause your ventricular depolarization. That is why you are going to get a QRS complex, following which you are going to get ventricular repolarization, which is your P wave. P, QRS, T, right? Now, so this particular PQRST arrangement generally happens when the rhythm is generated by your SA node. So please note that when SA node is your rhythm generator or your pacemaker, there is always going to be anterograde activation of your atria. Because there is anterograde activation of your atria, you are going to get an upright P wave. So when we are talking about sinus rhythm, we had discussed this already, but when we are talking about sinus rhythm, what are the characteristics of sinus rhythm? First thing is P wave is going to be upright. P wave is going to be upright. In certain pathological conditions like say atrial enlargements, you might get an inverted P wave in some leads, but generally when you look at sinus rhythm, you are going to get an upright P wave. Second characteristic feature is when the rhythm is constantly generated by your sinus node, sinoatrial node, the P wave is going to be upright and it is going to have a similar morphology in all the PQRS complexes. So all P waves will have similar morphology. Third most important aspect of a sinus rhythm is that you are going to get what? A PQRS relationship, which is a maintained PQRS relationship. For every P wave, you are going to get a QRS complex. Third characteristic feature. And finally, what is the fourth characteristic feature of sinus rhythm? I told you in the last class itself, when there is activation of your ventricles from a level which is above the ventricle, say your sinus node or your AV node or any point in your atria, what are you going to get? The remaining aspect of your depolarization is going to be a constant, say from the bundle of His to bundle branches, etc. Now, because now imagine that you are having a normal heart and the bundle branches are working normally, the Purkinje fibers are working normally, then the right and the left ventricular depolarization will be coupled. So it is going to be finished within a very, very short span of time. And ventricular depolarization is given by your QRS complex. So when the activation of ventricles happen from a point which is above the level of ventricle, you are going to get a narrow QRS complex. So narrow QRS complex. So this is the general characteristic of a sinus rhythm, right? Now, when you look at a sinus rhythm, you do have certain important variables. The normal firing rate of your SA node is around 60 to 100, right? 60 to 100. So when the particular, all these points are being maintained, P wave is upright of similar morphology, the PQRS relationship is maintained, and you're having a narrow QRS complex. And when the heart rate is between 60 to 100, then you call that as normal sinus rhythm. The first and the most common variant of sinus rhythm that you will observe in an ECG is normal sinus rhythm. So if you want to identify the pathological issues, you obviously need to identify normal sinus rhythm. The second variant that you can get in sinus rhythm is something which is called as sinus bradycardia. So in sinus bradycardia, once again, you are going to get all these variables which are maintained. You are going to get a regular rhythm, but the rate is going to be less than 60. So in sinus bradycardia, all these points will be maintained. Along with that, it is going to be a regular rhythm. And along with that, one important characteristic feature is that the rate is going to be less than 60. Third important variable that you're going to get is a condition which is called as sinus tachycardia. So I told you the normal firing rate of your SA node is 60 to 100. So if the rate is more than 100, it is called as sinus tachycardia. The PQRS relationship will be maintained. All P waves will have similar morphology. P waves will be present. And also the PQRS complex is going to be narrow. The rhythm is going to be regular. This is sinus tachycardia, rate more than 100. Please do keep in mind that generally when tachycardia is of sinus in origin, the rate is generally confined to less than 150. So sinus tachycardia generally happens in the rate of 100 to 150. So please do remember, when it comes to sinus tachycardia, you can have some important points. Now this is P wave, this is QRS, and then this is your T wave, then again P wave, QRS, T wave, then again P wave, QRS, T wave. Like, so if the rate is more than 100, it is called a sinus tachycardia. Now, the condition which is very, very similar to sinus tachycardia is something which is called a supraventricular tachycardia. I told you the characteristic feature of supraventricular tachycardia is that there is going to be absent P waves. There is going to be absent P wave, and along with that, you are going to get what? Absent P wave is the characteristic feature of supraventricular tachycardia. But one thing that can happen commonly with sinus tachycardia as well as supraventricular tachycardia is that, or any tachycardia which can produce supply-demand imbalance, you can get a secondary STP change. For example, in sinus tachycardia, you can get a normal or a secondary ST depression and T wave inversion. So this particular QRS complex or PQRST can also look like PQRST. Then again PQRST, PQRS, sorry. So this is how it can look like. So you can get secondary ST changes, that is ST depression and T wave inversion whenever you are having tachycardia. That can happen in sinus tachycardia, that can happen in your supraventricular tachycardia as well. So when it is sinus tachycardia, P waves will be present. Please do not forget that. In supraventricular tachycardia, your P waves are going to be absent and the rate is going to be more than 150. This is how you differentiate sinus tachycardia and supraventricular tachycardia. The last rhythm in sinus, which is very, very important, is something which is called as sinus arrhythmia. I already discussed in the last class. As you mentioned, every characteristic of a sinus rhythm will be maintained, which is P, QRST relationship will be maintained. For every P wave, there will be a QRS complex. For every P wave, there will be a QRS complex that is going to be maintained. The QRSs are going to be narrow. The P wave morphology is going to be the same. The only thing that is going to vary in your sinus arrhythmia is that you can get an irregular rhythm, which means your RR interval can vary. So imagine that this is your first QRS complex that you're looking. This is the second QRS complex. Thirdly, it can happen here. And then the fourth can happen here, etc., etc. So the notable important point that you should understand is that in sinus arrhythmia, you are going to get every features of a sinus rhythm, but along with that, you are going to have an irregular rhythm, which is RR interval is going to vary. Now, when the RR interval varies, which is generally irregular rhythm, you do have two important common diagnoses. You do have so many differentials, like for example, PVC, PAC, etc., etc. But generally, when they ask you a question, when there is an irregular rhythm, you only have to suspect two conditions. One is obviously your sinus arrhythmia, but more importantly, the most favorite question in all of the ECG-based questions which have come in your NEET exam, INICET exam is something which is called as atrial fibrillation. So please do remember that for your entrance point of view, when you get an irregular rhythm, you suspect two things: sinus arrhythmia or atrial fibrillation. Now, how do you differentiate sinus arrhythmia and atrial fibrillation? Extremely simple. You look whether P waves are present or not. If P waves are present, it is a sinus rhythm. If P waves are absent, it is atrial fibrillation. So how do you differentiate sinus arrhythmia and atrial fibrillation? You just look at the P wave. If every QRS complex is preceded by a well-defined P wave, it is sinus arrhythmia. If P waves are absent, it is atrial fibrillation. In your atrial fibrillation, P wave will be replaced by something which is called as a fibrillary wave. Right? So 3 or 4 variants of sinus rhythm we have already discussed. Now let us discuss something which is called as junctional tachycardia or junctional rhythm. Okay. So let me discuss about junctional rhythm. So junctional rhythm. So junctional rhythm essentially means your SA node is not working and your AV node is going to work. So AV node is going to be your rhythm generator in junctional rhythm. It can happen when the SA node is not working in conditions like severe sinus bradycardia, or it can happen in conditions like sick sinus syndrome. Junctional rhythm can happen as an escape phenomenon because essentially your SA node was supposed to generate rhythm and it is not. So the heart is trying to escape out of this particular crisis, and sometimes it can generate SA node. Or you're having some structural problem there in your SA node. It is not generating your rhythm. Your junctional rhythm is going to take over. The characteristic feature of junctional rhythm is, let me again draw your heart here. Okay. Let me draw your heart. It is very, very important that you understand the physiology of junctional rhythm. This is your SA node. Obviously, it is not working. So AV node is what is generating your pacemaker rhythm, right? So AV node is going to cause conduction anterograde depolarization of your ventricles like before. But if you look at atrial depolarization, there is a slight change in direction. Now atrial depolarization will be conducted in a retrograde direction because obviously your AV node is your rhythm generator. So AV node is going to cause atrial depolarization as well as ventricular depolarization. Now, as far as ventricular depolarization is concerned, it is going to go through a normal pathway, which is from the AV node to the bundle of His to the bundle branch to the Purkinje fibers. But when it comes to atrial depolarization, now the atrial depolarization is obviously going to proceed in the opposite direction. So there is retrograde activation of your particular atria, and retrograde activation of atria is going to be given by an inverted P wave. In sinus rhythm, I told you the first and foremost factor is upright similar P waves. Here you are going to get an inverted P wave. First and foremost characteristic feature is inverted P wave. Now remember one more important thing. We are talking about junctional rhythm. So there is going to be atrial depolarization and there is going to be ventricular depolarization. When it was sinus rhythm, you know that the initial activity is going to be atrial depolarization, and then you are going to have an AV nodal delay, and then you are going to have ventricular depolarization. But when it comes to junctional rhythm, your atrial depolarization is going to happen and ventricular depolarization is going to happen more or less at the same time. So you are not really going to have the conventional PQRS relationship. Yes, you can sometimes have the conventional PQRS relationship, but you can also have a scenario where atrial depolarization and ventricular depolarization is happening at the same time. Or you can also have a scenario where your atrial depolarization is going to happen only after the ventricular depolarization. Now, if you want to convert this physiological knowledge into ECG knowledge, I'll tell you that you might have a scenario where you are going to get an inverted P wave following a QRS complex like this, and then you are having the T, or you can also have your particular P wave submerged inside the QRS complex because your atrial depolarization and ventricular depolarization is happening at the same time. Or you can also have a scenario where the P wave happens immediately after the QRS complex like this. So this is your QRS complex, this is your ending here, and suddenly you are going to get an inverted P wave here. So this particular is something which is called as P wave. So the characteristic feature of a junctional rhythm is, again, because it is junctional rhythm, there is activation of ventricle from above the level of ventricle. So you are going to get a normal narrow QRS complex. The P waves are going to be inverted. Now, generally, if you see, I told you SA node can have a firing rate of around 60 to 100, but when it comes to your junctional or your AV node, it can only fire up to around 40 to 60 per minute. So you expect the junctional rhythm to have a rate of around 40 to 60. It is characterized by inverted P waves. Please do not forget that it is inverted P wave. And that inverted P wave can either precede your QRS complex, or it can happen during the QRS complex, or it can happen just immediately after the QRS complex. The rate is going to be between 40 to 60. Right? Now, so let me just write that down. Inverted P wave, and the timing of P wave can be like just before or during or just after your QRS complex. The QRS complex is going to be narrow. The QRS complex is going to be narrow. Whenever we are saying something, there is always a possibility of an exception. You have something which is called as junctional rhythm with aberrancy, where you can get sometimes wide QRS complexes, but generally the QRS complex is going to be narrow. And third important thing is a rate is going to be 40 to 60. So if you are not getting a P wave, you are only getting a QRS complex with T, the rate is around 40 to 60. That is also junctional rhythm. In the next class, we are going to do an ECG quiz where I'm going to show you 20 high yield ECGs, and I'm going to make you diagnose every ECG on the spot. Okay, so for that, your understanding of this particular understanding is very, very important. So this is how you call it as a junctional rhythm. You have two variants for your junctional rhythm. I told you the normal rate of junctional rhythm is around 40 to 60. Sometimes what you can have is, this is your inverted P wave, your QRS complex and T wave, your inverted P wave, QRS complex and T wave, your inverted P wave, your QRS complex and T wave. If you look at the rate, the rhythm is going to be regular, obviously, but the rate is more than 60, but less than 100. Now, in your normal junctional rhythm is never normal, but generally when junctional rhythm happens, you expect a rate of 40 to 60, but you are having a scenario where the junctional rhythm is having a rate which is between 60 to 100. This is what is called as accelerated junctional rhythm. Okay, this is what is called as accelerated junctional rhythm. This is what is called as accelerated junctional rhythm. Because it is still not tachycardia. If you want to call it as tachycardia, you need a rate which is more than 100. You are getting a similar appearance, but the rate is more than 100 means it is junctional tachycardia. Let me use a different rhythm here. Okay, this is your QRS complex, and there is a P wave here, then T wave, QRS complex P wave, then T wave, QRS complex P wave and T wave, QRS complex P wave and T wave. This rate is more than 100, then it is called as junctional tachycardia. So what are the variations you are going to get in junctional rhythm? You are going to either get a junctional rhythm or accelerated junctional rhythm or junctional tachycardia. Okay, these are all abnormal rhythms. So sinus rhythm done, junctional rhythm done. Finally, let me talk about a rhythm which is called as ventricular rhythm. Okay, idioventricular rhythm or ventricular rhythm. Ventricular rhythm. So what are the important characteristic things that you should understand? Once again, I'm going to draw a heart here. Let me take a new page. Okay. Okay. Right. So this is your heart here. Okay. So in idioventricular rhythm, it generally means that the rhythm is being generated by one particular point in your ventricle. Your SI node is obviously not working. Your AV node is not working. The rhythm is generated from either bundle of His, or it is generated from any of the bundles. Now, the characteristic feature is generally when you are having a ventricular rhythm, obviously atrial depolarization is not happening. So the first point is there is going to be absent P waves. Second important point, when it is about your ventricle, if you look at the pathway of your ventricle, they generally do not really have a higher firing rate. So their rate is only 30 to 40. Their rate is only 30 to 40. Third important point, I told you when you are having a stimulation of the ventricle, it is happening from a point which is above the level of ventricle, you are going to get a narrow normal QRS complex. But imagine, say, this particular point is your ventricular depolarization pacemaker. Then obviously your right ventricular depolarization is going to happen fast. Your left ventricular depolarization is going to happen later. The whole point is when there is ventricular depolarization or ventricular rhythm, there is going to be decoupling or uncoupling of your ventricular depolarization. The right and left ventricular depolarization will happen at different time frames. Hence, you are going to get a wider QRS complex. The duration of QRS complex will be more than 0.12 seconds. Or if you want to have a graphical idea, see, this is one large square where you have small 4 divisions, right? So if you look here, one small box is 0.04 seconds. So if you multiply that into 3, you get a value of 0.12. So generally, if you look at the duration of your QRS complex, the maximum duration can have even up to maximum 3 small squares. But if it is more than that, it is called as a wide QRS complex. So the characteristic feature of your ventricular rhythm is absent P wave, rate around 30 to 40, and characterized by wide QRS complex. That is how you divide or understand regarding supraventricular tachycardia and ventricular tachycardia. Right? Supraventricular tachycardia is characterized by narrow QRS complex tachycardia, whereas your ventricular tachycardia is generally wide complex tachycardia. Now, this is your general idioventricular rhythm. So how does it look? You are going to get a broad, wide QRS complex. Let me draw it here. This is one broad, wide QRS complex. You can also note that there is no P wave here, right? And the rate is going to be around 30 to 40. You can also have this in a different way, like this. Initially, you are going to get an inverted pattern, right? So it can either look like the first one or it can look like the second one, but no P waves. You are going to get a rate around 30 to 40 wide QRS complexes. This is what is called as your normal. Sorry, again, it is not normal. This is the conventional idioventricular rhythm. Again, just like your junctional rhythm, you can have variance here in your ventricular rhythm as well. Now, this is your normal ventricular rhythm, right? So this is your conventional ventricular rhythm where the rate is around 30 to 40 per minute. Now, let me tell you about one variant where the rate is more than 40, but similar in your morphology of the QRS complex. If you want to draw here, this is one QRS complex, this is second QRS complex, this is third QRS complex, this is fourth QRS complex, etc., etc. No P waves, nothing. You're only getting this kind of an image. But if you look at the rate, the rate is ranging between 40 to 100, which is not expected out of a conventional ventricular rhythm. So this is what is called as, just like what we mentioned in your junctional rhythm, this is what is called as accelerated ventricular rhythm. Accelerated ventricular rhythm. Right? You can also have one more important variant where you are going to get this in even higher rate. So it is going to look like this, right? It is going to look like this, right? This is just wide QRS complexes happening at a very, very rapid rate. And this is what is called as your ventricular tachycardia. This is a cardiac arrest rhythm. So please do look at it. This is why your ventricular tachycardia is going to look like this. This is your idioventricular rhythm. This is your particular accelerated idioventricular rhythm. This is ventricular tachycardia. Now, I want to add a few points on ventricular tachycardia. I told you your ventricular tachycardia essentially means you're going to get wide QRS complexes at a very, very rapid rate like this, right? You can also have, see, if you look here, all QRS complexes that I've drawn here, they almost look like the same. So there are no two different morphologies here. All your QRS complexes are looking like the same, and it is a tachycardic rhythm. It is called as monomorphic ventricular tachycardia because everything looks like the same. Now, the second important variant that you can have is some of the QRS complex can look like this, some can look like this, some can look like this, etc., etc. So when you are getting different morphologies, if the morphology is more than one, then it is called as polymorphic ventricular tachycardia. Now, I want to give you an example of a polymorphic ventricular tachycardia. So this is, again, you can see that there is one particular wide QRS complexes. Suddenly you are seeing a small QRS complexes, and suddenly wide again you can see like this. So this particular kind of appearance here that you are seeing, it looks like this is again wide QRS complex tachycardia itself, but you see that it looks like this particular QRS complex is twisting on its axis. So this is a type of polymorphic ventricular tachycardia which is called as Tosadus deep point, it's TDP, right? This is a variant of polymorphic ventricular tachycardia. And finally, Imagine this is ventricular tachycardia where there is actual contraction of your ventricle but not effective. You can also have a further fatal variant of this particular thing where there is ineffective contraction of your ventricle. Rather than having contractions like this, your ventricles are going to just have minimal movements, fibrillary movements. This is what is called as ventricular fibrillation. So how do you think ventricular fibrillation is going to look like? It is not going to have such defined morphologies for QRS complex. Instead, your whole isoelectric line will be replaced by fibrillary waves, just like this. It is just going to look like this. So this is your ventricular fibrillation. So this is it for today. What we have done today is we have made you understood how to identify sinus rhythm, how to identify junctional rhythm, how to identify the variants of junctional rhythm, how to identify ventricular rhythm and its various. What do you mean by monomorphic ventricular tachycardia? What do you mean by polymorphic ventricular tachycardia? The one variant of ventricular tachycardia which is called as tosadus de pointis, and finally ventricular fibrillation. I had discussed about supraventricular tachycardia, atrial fibrillation, and flutter in the last video. So tomorrow we are going to have a short 5-minute discussion on AV blocks, following which we will have a quiz of 20 must-know ECGs for your entrance exam. So I was preparing yourself for understanding and identifying that by yourself. So I hope you are going to enjoy tomorrow's session where I'll be doing a rapid revision of 20 must-know ECGs for your entrance exam. Trust me, this is going to be extremely useful for you when you are trying to give an INICET exam. Okay, so I hope you enjoy this discussion. I'll come again tomorrow. Have a good night. Thank you.
இது கனெக்ட் பண்றதா? Connect this. Hello, all of you. Welcome to today's surgery class on expected questions for INICET and also upcoming NEET SS and NEET PG exams, NEET PG that is going to happen in April 2022. So the question reads here: a child was brought with a history of dysphagia. On inquiry, mother informed that the child was playing alone and gives a history of foreign body. X-ray was done and images are shown below and the likely site of foreign body. You can see a radio opaque shadow here, both in the epilateral views, and you are able to see that, and you need to tell the examiner where it is. Is it there in the trachea, larynx, esophagus, bronchus? So the right answer for this question is esophagus. Now, you can see the coin typically like a slit, right, in the lateral view, and the coin size as in the AP. Now, definitely it is below the larynx and trachea if you see the position. So it is almost there in the thoracic inlet. And if suppose this is going to be in the trachea, then probably it could have caused an obstruction and the air entry may not be equal on both sides. And there could be some difficulty in those aspects. And not only that, a coin in the trachea is very difficult to even take an X-ray because child will be restless, have a respiratory distress, and probably they go for an intervention to remove it at the earliest. That will have been very important. So uniform air entry and positioning, and also the slit-like appearance, because esophagus is a collapsible structure. Esophagus is a collapsible structure, so it can appear, coin can appear like this. So the answer is esophagus. So based out of this, there could be many questions it can be asked. The question that could be asked on these lines is, what is the narrowest part of GIT? The first option is, the first answer is cricopharynx. Number two is, number one is cricopharynx. Number two is ileocecal junction. And close to ileocecal junction, if we say, could be 60 centimeter, proximal to ileocecal junction, and that side is also narrow because that's the side, that is the side of the vital intestinal duct during embryonic life. So the narrowest part in GIT, number one is cricopharynx, number two is ileocecal junction. So if any foreign body that is able to get across a cricopharynx can get caught in the ileocecal junction, the second, if it crosses ileocecal junction, it will be out naturally. Understood? So that's how it is. And they can ask you, what is the most common foreign body? The most common foreign body is fishbone. And they can ask you the most common site of lodgement of fishbone. The size is very small. So where is the most common site of lodgement of fishbone? The answer is tonsils, tonsillar fossa. Tonsillar fossa, followed by pyriform fossa and sinus. Tonsillar fossa number one, pyriform fossa and sinus number two. Is it okay? So these are the possible questions that can be asked. And whenever they ask you how to remove a foreign body, suppose there is a foreign body in the esophagus like this, how to remove it? Endoscopically. Endoscopically, you can visualize the coin and put a snare and hold the foreign body and to pull it out. Okay, that is a method. And if it is little in the mid third of the esophagus, lower third of the esophagus, or it is very difficult to manipulate, and the coin can be comfortably pushed into the stomach, and then the stomach will have more space, and you can manipulate and you can put a snare and you can hold the coin very well and you can remove it. Okay. And other than the coin, what are the other foreign body the children can swallow, or the pins, safety pins, button batteries, which are used for the soft toys, that can be swallowed. And if it is a closed safety pin, it can be removed quite easily with endoscopy. If it is an open safety pin, and the removal should be very careful, because the risk of injury to the mucosa and to the esophagus and can cause perforation. So very, very important. In that situation, a careful removal is advocated. So button batteries, what are the problem with button batteries? When the child swallows a button battery, it can go into the stomach and it can get auto-digested by the hydrochloric acid, and what can happen is that can cause whatever the storage material in the button battery, either the lead or lithium or mercury, whatever it is, and the release of that in the stomach can be a poisonous. So that is very, very important. Understood? And tracheal foreign body or rare, but still it can happen. And but it causes more distress to the patient and warrants immediate removal. And dentures, what are the other important things? Usually the people who have dentures remove the dentures when they sleep. And so in case accidental swallowing of dentures are also possible in the esophagus, and removal of dentures is also advocated. So all these are very, very important with regards to the swallowing of foreign body, and the background knowledge of that might help you to answer any question in the exam. Are you able to understand what I say? And great that you have been part of SPEED, and I also request those who have not been in SPEED, kindly register for SPEED and SPEED Learning app, because you have very good faculties and definitely you will learn the subjects with a lot of passion, love and joy, with joy. So, and you will definitely feel very happy about being a part of this program. So I request all of you to subscribe SPEED Learning app for your PG preparation. And SPEED is almost 20 years old institute which has trained more than 2 lakh students for postgraduate and super specialty exams. So I welcome all of you, and please register and join, be part of SPEED. Thank you.